Good evening, everyone. Welcome back to the review of pharmacology. So, yesterday we were discussing about lots of topics, right? So, guys, let's discuss inner details of other topics today. And along with that, now please pay attention to this particular thing, what I'm telling you. So throughout the discussion, I will be telling you people some points as the repeated questions which are asked. So I want you to note those questions because those are very important and they will be asked again and again because see, you need to understand the trend of the exam. Before even starting the topic, please understand the trend of any exam. Good evening everybody. So the trend is like this. Now, when you look at a trend of any exam, now we need to understand what are the frequently asked questions and frequently asked topics. That's your first thing to be paid attention on. Second thing, what are the clinically important aspects from any given topic? If you know these two things, you can master a subject. So that is very important, right? So many people are thinking, sir, everybody will tell this idea, but nobody will tell us what to do, right? So again, once again, good evening everyone. Now listen to me. I'll tell you one basic idea. So many people would be telling you, study these 4 pages, study these 4 lines, study this particular page of the sentences. Okay. So please don't go for that. Please don't go for that. I would tell you people to understand what is that. That is, whenever we tell you this particular mechanism is important, whenever I tell you this particular thing can be applied in other subject, that is the point where you need to catch on. Okay, but if you leave that particular point, then go and remember other things that will be of useless, right? So that is the first thing. Second thing, how you can remember complete pharmacology. So how to remember pharmacology? The technique is very, very simple. What is that? Don't remember the names of the drugs in the first itself. So put the names of the drugs for the ending of the discussion. Okay, what you need to do first. Okay, if I tell you a group of drugs, so what you need to do? Definition. Then how do they work in the body? Okay, then the next thing, what is that? What is the use of the drug? Then if you go and remember the names, then it will be very easy. Okay, so let's start, right? So yesterday we were talking about adrenaline and as well as noradrenaline, right? So simple as that, adrenaline has a beta 2 effect also, noradrenaline has no beta 2 effect. Based on this, there is one clinical importance which will be applied, I told you people, that is on the vasomotor phenomenon of Dales. Now, in vasomotor phenomenon of Dales, the question will be like this for you people. A patient was given a adrenaline in the presence of a alpha blocker. What will happen to the blood pressure? This is a standard MCQ. Blood pressure will be decreased. Blood pressure will be decreased, right? So, with that much being said, let's go to the next important aspect. What is that? There is one drug called as isoproterenol. What is that? Isoproterenol. Isoproterenol. Now, isoproterenol, what is this drug? This is a type of drug which is having only beta 1 and beta 2 agonist property. Beta 1 and beta 2 agonist property. So these are the three things which you need to understand: catecholamines and catechol derivatives, adrenaline, noradrenaline and isoproterenol. These three drugs, what are those three drugs? Adrenaline, noradrenaline and isoproterenol. Now among these three drugs, as I have told you people, you need to remember isoproterenol is a non-selective beta agonist because it is stimulating both beta 1 and beta 2 receptor. Got it? Got it? Okay. Now, nowadays we don't use this drug, but usually earlier time it was used. It was used for treatment of bradycardia. Treatment of what? Bradycardia. Okay. Now, this is a story of your adrenaline, noradrenaline and isoproterenol, but this is not the major focus here. The major focus will go to you people with specific drugs. So, let's learn them, right? Now, when we need to understand that, very, very simple and very, very basic. What is that? That is your first thing. Alpha agonist. What is that? Alpha agonist. Now, my dear brilliant students, alpha agonist, you people will tell me alpha agonist. So, before going there, you people should tell me alpha 1 and alpha 2 locations. Alpha 1 receptor located in the blood vessel. Very good, very good. Alpha 1 receptors are located in the blood vessel. If you stimulate alpha 1, they will cause vasoconstriction. They will cause vasoconstriction leading to increase of the BP if systemically applied, right? Okay. Now, gestational diabetes. So let me, Dr. Hussain, let me clarify this. For the gestational diabetes, metformin is not used. The only best drug for the gestational diabetes is insulin. Clear? Now, listen to me guys. So, it will cause vasoconstriction and increase BP, but understand alpha 1 agonist, understand what and all we can get the effect. There are other effects also. What are the other effects? One of them, they will cause nasal decongestion. What is that? Nasal decongestion. Nasal decongestion. Along with the nasal decongestion, my dear students, they are mydriatic agents. What are those? They are mydriatic agents. What is that? Mydriatic agents. Okay. Now, these mydriatic agents, what are these mydriatic agents? So, they will cause dilation of the pupil, but without cycloplasia. What is that? Without cycloplasia. Now, cycloplasia, I told you people yesterday. What is cycloplasia, my dear students? Paralysis of the ciliary muscle. Very good. Now, whenever I use these drugs, they will cause mydriasis. But if you notice, without cycloplasia, so they will cause the dilation of the pupil, but there is no paralysis of the smooth muscle, so paralysis of the ciliary muscle. So the question will be like this: which drugs will cause mydriasis without cycloplasia? Let's pay attention again. Without cycloplasia, they are your alpha 1 agonist. So what are the drugs we have? Understand, we have a drug called as phenylephrine. What is that? Phenylephrine. What is that? Phenylephrine. Phenylephrine causes mydriasis without cycloplasia. Without cycloplasia. Now, please understand nasal decongestion. Nasal decongestants, we have drugs such as oxymetazoline. Oxymetazoline. There is one more drug called as xylometazoline and oxymetazoline. Metazoline drugs are your nasal decongestants, and phenylephrine is your, what is that, my dear students? That is your mydriatic agent without cycloplasia. Phenylephrine, some cases, earlier times, there was a tablets which were used to be available for the nasal decongestion itself. Okay. Now, please understand, the MCQ will be like this. So, mydriasis without cycloplasia, the answer is phenylephrine. Question number 1. The second one, mydriasis with cycloplasia, then that will be your anticholinergic drugs. Among those, for children, atropine. For adults, what is the name of the drug? That is your tropicamide. These are the 3 important MCQs which you need to remember. Clear, everybody? Very good. Atropine is used, but other drugs also there, right? Now, let's continue. Alpha 1 agonist, we understood about this. Now, alpha 1 agonist, guys, once we know about this, let's go to the next important aspect. What is this? Guys, this is the one of the most important aspect, that is your alpha 2 agonist. Alpha 2 agonist. Now, when I want to teach you people about alpha 2 agonist, please listen to me. Alpha 2 receptor, if I stimulate this alpha 2 receptor, what it will do? It will decrease the release of, your adrenaline, noradrenaline, that is basically neurotransmitters. If they were decreasing the release of the neurotransmitter, they will decrease the sympathetic activity. They will decrease the sympathetic activity. That means they will decrease the blood pressure. They'll decrease the blood pressure. If they're decreasing the blood pressure, they can be use of the alpha 2 agonist. The use of the alpha 2 agonist, you people will tell me. So if blood pressure is decreasing, where do we use? Please tell me. Let's see. Let me look at the comments. So, of course, the use will be wherever if something is decreasing the BP, of course, it is used in the treatment of hypertension. Used in the treatment of, very good. That is in the hypertension treatment. Now, guys, please understand here. What is that? If they're used for hypertension, what are the drugs? So, there are 2 drugs. What are those? There is a drug called as clonidine. There is one more drug called as alpha methyl dopa. So there are 2 drugs, alpha methyl dopa and clonidine. Now among these 2 drugs, if I have to pick one drug for the pregnant female, see, for pregnant female, if she gets a hypertension, the drug of choice is labetalol. Okay, the drug of choice is labetalol. I'm not going to confuse you people. Drug of choice is labetalol. But apart from labetalol, alpha methyl dopa is also safe in pregnancy. Is also safe in pregnancy. So which means you can use alpha methyl dopa in a female with a pregnant female with a hypertension. That is the story of your alpha 2 agonist. This is an important aspect. So apart from that, my dear students, you need to understand these two drugs you understood. Okay. Now, apart from this aspect, these drugs also used in the glaucoma. What is that? Glaucoma. Okay. Drugs such as brimonidine. Drugs such as brimonidine. Okay. So, brimonidine is a drug which is an alpha 2 agonist. See, if you can understand here, alpha receptors are present in the presynaptic membrane of the neuron, blood vessel, as well as other locations. That is in which particular areas? In the particular areas such as there are some centers of the brain which is responsible for the addiction. Even there also clonidine is used. That is an in-depth aspect to it, but the most important exam-oriented aspect, alpha methyl dopa brimonidine is used in the treatment of glaucoma. This is the story of your, what is that? Very good, alpha 2 agonist. So once alpha 2 are done, what is left out? Of course, beta are left out. So beta is very interesting. Okay. So beta is acting upon the heart. So that is very, very much important for you people. Let's look at that. Beta agonist. What is that? Beta agonist. Okay. My dear students, when I want to teach you people about beta agonist, what are the receptors we have? Let's look at them. Beta 1 receptor. Beta 1 receptor. They are located in your heart. Okay, sir. If they are located in your heart, it is like your, what is that? If you stimulate the beta 1 receptor, in the heart, it will increase the heart rate. Okay, it will increase the force of contraction. It will increase your O2 demand. All of you know it. But the most important aspect here, guys, please pay attention. So beta 1 effect on the heart. How to remember? You can remember it like fighting with your girlfriend. Whenever you fight with your girlfriend, what is going to happen? She will start to argue, then your heart rate will rise up. Like that only, heart rate will increase with the stimulation of beta 1 receptor. So, my dear students, where do I have to increase the heart rate? Agreed, in bradycardia. But where do I have to increase the force of contraction? In one condition, in a heart failure condition. So, beta 1 agonist, we have drugs such as dobutamine. What is that? Dobutamine. Now, dobutamine is used, a drug of choice for your acute heart failure. Now, many people will jump into the comment section saying that, sir, dopamine also can be used. Agree with you, my dear. Dopamine can also be used. The best drug, if I want to prefer, this is selectivity to beta 1 receptor. Then let's prefer beta 1 agonist, that is dobutamine. And there is one more drug, as you people going to say, that is your dopamine. What is that? Dopamine. Now, dopamine at which type of thing? See, dopamine has a dose-dependent action. What is that? Dose-dependent action. At which type of doses? At the doses of medium doses. Which is about 2 to 10 microgram. So this is the story of your heart failure related drugs which are used for acute heart failure. Now remember, beta 1 agonist are which type of drugs? If I was the question examiner, I would make a question in totally different way. A patient who presented with the symptoms of acute heart failure was given a dobutamine. This can be explained by which effect? Remember, that effect is positive inotropic effect. What is that? Positive inotropic effect will be achieved as a result of your dobutamine. This is a very important MCQ. Please understand what is that positive inotropic effect. What is that? Positive inotropic effect. So this is a very, very important aspect for you people to be remember. Positive inotropic effect. So that will positive inotropic effect which will increase, what is that? Increase increase the heart rate, along with that increase the force of contraction. This is a very important aspect to be remembered, guys. So with this much being said, we are done with the beta 1 agonist. But beta 1 receptor not just located in the heart, but also located in the kidney. There in the kidney, leading to what? Leading to the activation of the RAS system, which we will learn today in the antihypertensive drugs. Just keep watching. All right. Okay. So in the case of right heart failure, what is the drug of choice? My dear, the presentation matters. Okay. So if I have a patient with a chronic heart failure, be it a right heart failure, be it a left heart failure, I would prefer, what is that? Digoxin. If it is a chronic heart failure. If it is acute heart failure, I would prefer dobutamine. If not, medium dose of dopamine. Got the point? Okay. Now, once we understood about beta 1 agonist, now let's proceed to the next aspect. What is that next aspect? So if beta 1 agonist is done, beta 2 agonist, oh my god, beta 2 agonist is every medical student's favorite. Why? Because saba laba, there is one saying, right? So we will use that only, but let's understand. Beta 1 agonist, we are having, see, beta 1 agonist, we are having dobutamine and dopamine. Beta 2 agonist, we have saba and laba. Let's learn about it. Beta 2 receptor, they are located in your bronchus, they are located in your bronchus, they are located in your blood vessel, they are also located in your uterus, If you notice the common point among these three things, the common point is smooth muscle. What is the common point? Smooth muscle. Now all of you have learned saba laba. I'll ask you a simple question. The simple question will put a trap for you. So this beta 2 agonist act with the help of which protein kinase? Let's see. Comment. Take a guess. Okay. Even if you don't know, why am I here? To make you people learn. Let's learn. Let's consider this is one smooth muscle cell upon which I have which receptor? Beta 2 receptor, my dear students. What is that? Beta 2 receptor. Now, beta 2 receptor, what is there? If I stimulate a beta 2 receptor, what is going to happen? What is going to happen? It will lead to the increase of the CAMP. Okay. Now this CAMP in turn will stimulate one enzyme called as protein kinase A. Now this protein kinase A will inhibit somebody called as MLCK. Now listen to me very carefully, guys. What I'm trying to tell you people, MLCK is nothing but myosin light chain kinase. Myosin light chain kinase usually cause the contraction of the smooth muscle. If I block that myosin light chain kinase, I'm gonna get the relaxation. So this is an important MCQ which was asked. So beta 2 receptor acts via which protein kinase? Protein kinase A. How to remember this, sir? Beta B A B. You can remember A. Protein kinase A works with beta receptor. Clear, everybody? Clear? Okay. Now, please understand what happens. MLCK inhibited means in the bronchus, bronchodilation. Along with that, there is a vasodilation. What is that? Vasodilation. Along with that, uterine relaxation. Okay, sir. If these three are there, now what we are going to get? Let's understand. Uterine relaxation, there is a vasodilation, and there is a bronchodilation. Now, for that purpose, we are going to uses of these drugs. So uses of these drugs, it is used in the treatment of bronchial asthma. If the MCQ says, listen to me very carefully, if the MCQ says drug of choice for asthma, okay, now the answers will be like this. Option A, steroids. Option B, beta 2 agonist. Okay. Yesterday I taught you people some drugs. What are those? M3 blockers. That is ipratropium. Okay. Option D, none of the above. Okay, give me an answer, let's see. If the question says like this. Drug of choice for asthma, steroids, beta-2 agonist, ipratropium, and none of the above. What would be your answer, guys? I'm looking for your comments. Beta-2 agonist, somebody says, okay. Now, why can't we use steroids? Yes, why can't we use ipratropium, right? Tell me, others. So, please focus here, okay. See, any other answers, please? Okay, now listen to me very carefully. What is that? I'm trying to tell you people, if they tell you only something like drug of choice for bronchial asthma, no other data is given, no other data like mild, moderate, severe, nothing about it is given. If nothing about it is given, then your answer should be always beta-2 agonist. Beta-2 agonist. Beta-2 agonist are the first line of the drugs which we start for a patient of the bronchial asthma. Got the point? Got the point? Okay. If the question, if I change drugs used in asthma, then all of the above. Drugs used in asthma, all of the above. Got the point, everybody? Okay. Now, apart from asthma, they're used in COPD. They're used in COPD. Now, they're also used in premature labor, preterm labor. Preterm labor. Now, when I'm talking about a preterm labor, the drug which is specifically developed for the uterus is Ritodrin. But do we use this drug nowadays? No, we have a better drugs such as tocolytic agents, such as calcium channel blockers. So we are going to use those drugs rather than the beta-2 agonist. But they can ask you which beta-2 agonist is used for the tocolytic or a uterine relaxation. Okay. Now all the drugs are divided into two types. All the beta-2 agonists are divided into SABA, short-acting beta-2 agonist, and there is one more way called as LABA, long-acting beta-2 agonist. Now, SABA, what is that? SABA, okay? Now, it's SABA, guys. It's not Shiba, it's SABA, okay? If somebody with Shiba name sees that, please don't get offended, okay? Now, SABA, what is that? We have a drug called as salbutamol. Okay? Then, any other drug? We have one more drug called as terbutaline. Okay, so these are the two drugs which you need to remember. Okay, now LABA, what do we have, sir? Long acting, we have one drug called as salmeterol. We have one more drug called as formoterol. Okay, now metro goes all over the city, like that only you can remember. Long acting drugs will contain metro in them. This is one classic way which we have been remembering, formoterol and salmeterol. Okay, now remember we have a salbutamol, we have terbutaline. These are the short acting beta-2 agonist. But I'm least interested in this. There is one of the most important aspect, the side effects of these drugs, guys. Side effect of this drug, remember, it will cause one thing that is only called as reflex tachycardia. Okay, reflex tachycardia. What do I mean by this? Beta-2 agonist causes vasodilation. If there is a vasodilation, there is a decrease of venous return. If there is a decrease of venous return, heart will try to compensate by increasing the heart rate. That is only reflex tachycardia. Remember, reflex tachycardia can present as a palpitation. Got it? Palpitation. Okay. Now, apart from reflex tachycardia, is there anything else? Yes, of course. There is one more important side effect, that is your tremors. And it will also alter the blood glucose level. So these are the three important aspects. So how will a MCQ come for you people? A 25-year-old female who was a known case of asthma was given a drug. After that, she was not able to sleep in the night due to palpitation and tremors. Which drugs were given? Beta-2 agonist. Simple as that. This question was asked previously. So I'll repeat the question again. A 25-year-old female who was treated for the asthma was not able to sleep in the night because of the tremors, and one more thing, that is because of the palpitation. Now, what is the drug given? This drug given is beta-2 agonist. This type of questions are asked. This is a trick of the pharmacology. So throughout the theory, what you learned, the end summary is very important key point. All right. See, orthostatic hypotension is not a significant. Orthostatic hypotension Orthostatic hypotension, that is significantly seen with alpha blockers. Okay, then next thing, the drug of choice for tremors is beta blocker. My dear students, remember the drug of choice for what is that essential tremor, what is that essential tremor is beta blocker, that is your propranolol. Okay, not for every tremor blindly we will give beta blocker. For example, patient was having tremors as a result of some CNS disorder. Okay, but in essential tremor there is no such thing. No pathology is found, idiopathic tremor. So in that condition, you're going to give propranolol. Clearish? Okay, let's continue. What is that? We understood about SABA, we understood about LABA. Let's go next. What is that next part? So what is that, guys? We understood about beta 1, beta 2 agonist, alpha 1, alpha 2 agonist. Clear. Now, my dear students, once we know about this, let's go to the next important aspect. They are only were adrenoblockers. Adrenoblockers. I can challenge you people one thing. Adrenoblockers, I can 100% assure you that there will be MCQ. 100% there will be an MCQ, because this is a very, very important topic, because it has a twisted uses and very interesting information. So let's start. Adrenoblocker. If we are blocking adrenoreceptor, we are going to block either alpha receptor or we are going to block either beta receptor. So let's look at each one of them. So first important aspect, let's start with the alpha blockers. So alpha blockers, my dear students, these alpha blockers are divided into what? These alpha blockers are divided into two types. First one is non-selective. They are your non-selective alpha blockers. If non-selective alpha blockers means they are gonna block two receptors, alpha 1 also and alpha 2 also. Alpha 1 also and alpha 2 also. But non-selective alpha blocker, if they are blocking alpha 1 and alpha 2, we have two types. They are called as reversible, and there is one more drug called as irreversible. So reversible and irreversible, there are two types of blocker. Reversible blocker means what is that? For example, I have a drug which will block the receptor for 5 hours. So I have a receptor which is sitting like this. Now I gave a drug irreversible which works for how many hours? 5 hours. Okay. After 5 hours, what happens? My drug will disappear. After drug disappear, what will happen? The receptor will become active. This is a reversible. If irreversible means what? The drug will go and bind with the receptor. Receptor is destroyed forever. Now your body has to synthesize a new receptor for the alpha action. That is the summary. Now you people should pay very much attention, because I'm going to create a trap for you people. Let's see how many of you will catch on to it. Okay. Reversible drug. What do we have? We have a drug called as phentolamine. Now we have a drug called as phentolamine. There is one more drug called as tolazoline. So these two drugs are. Now irreversible. What is that irreversible drug? We have a drug called as phenoxybenzamine. Now you people have to focus here. How to remember these two drugs? Sir, if you notice here, sir, we have a phentolamine and tolazoline. Okay. And if you notice here, phenoxybenzamine. Which name is bigger? Phenoxybenzamine. If the name is bigger, you can remember it with this only. If the name is bigger, the duration of action is longer, because it is a irreversible blocker. So this is a long-acting drug. How to remember long-acting drug? A lengthy name. Okay. An lengthy name. That's what you need to do. You don't have to do all this extra mnemonics and a lengthy name. Okay. Long-acting and irreversible. Now, guys, let's go for the uses of this drug. Uses of these drugs, my dear students, they are very much important and interesting. Why they are very much important and interesting? Because of one reason. What is that one reason? Let's see. Now, these drugs are used for the cheese reaction. Now all of you might be thinking, what is this cheese reaction? Guys, cheese reaction is caused by a compound. This can also be an important MCQ. What is that? Cheese reaction is caused by which compound? Compound called as tyramine. Remember tyramine, not tyrosine. It is a tyramine. It is a compound called tyramine. So for this treatment, we use which drugs? Usually reversible drugs. Reversible. Now, apart from that cheese reaction, these drugs also used in one more place. These drugs also used in one more place called as pheochromocytoma. Pheochromocytoma. Now, pheochromocytoma, very good, Rahman, very good. That is tyramine, correct compound. Okay. Now, pheochromocytoma. Pheochromocytoma is what? It is a catecholamine secreting tumor. Catecholamine secreting tumor. Now you people might be thinking that, okay, what is the drug we can give? Then definitely, sir, tumor is there, we need a longer action, we are going to use which drug? Irreversible drug. What is it? Irreversible drug. Okay. Now, if you are talking about irreversible drug usage, now my dear lovely students, pay attention. You give a irreversible drug. Now, irreversible drug will go and block alpha receptor. It will go and block the alpha receptor. If it is going and blocking the alpha receptor, now what will happen? Still you need to understand one more thing. So what is that? Catecholamine producing tumor. So more of catecholamine already present and you give a alpha receptor blocker. If you block the alpha receptor, now adrenaline will act upon stimulate which receptor? Of course, vasomotor phenomenon of Dales. Beta 2 receptor. Which receptor? Beta 2 receptor. If beta 2 receptors are stimulated, then it will decrease the blood pressure. The patient might even go to shock. Now, patient with a pheochromocytoma came to with elevated blood pressure. You gave one drug without thinking. Single drug caused the patient into shock. Now, can you let this happen? No, because shock can kill the patient very instantaneously. So you need to avoid this. How can you avoid this? To avoid the shock, best combination is, what is that? That is your phenoxybenzamine. What is that? Phenoxybenzamine. Along with phenoxybenzamine, you need to add one more drug which block the beta 2 receptor also, that is your propranolol. Okay. Now you people might be confused, sir, it will also block beta 1. Yes, of course, beta 1 also, it will block beta 2 also, and we are going to use that property of beta 2 blocking here. That's it. Okay. So what is the summary? We need to combine phenoxybenzamine along with propranolol. That is the best combination for the treatment of pheochromocytoma. If single best drug, of course, sir, phenoxybenzamine. If best medical management is what? Propranolol. Every student would have made a mistake, and if you make this mistake, this can make a difference between 149 and 150. And all my students who are watching this and who are going to watch this, you need to make sure that this combination is used for the treatment of, what is that? Pheochromocytoma. Okay. Now, if you want to understand more about these drugs, we will learn especially the side effects. So look here, guys, alpha blocker side effect. We will come to alpha blocker side effect when we will come. Once we learn about alpha 1, very good. What is that? Alpha 1 agonist or antagonist? Of course, alpha 1 antagonist. Now, when you want to learn about alpha 1 antagonist, guys, understand here, alpha 1 receptor is further divided into, yes, sir, alpha 1A, alpha 1B. Okay. Now, alpha 1A is located in the blood vessel. Alpha 1A is located in the urinary bladder sphincter, and your alpha 1B is located in the blood vessel. Alpha 1B is located in the blood vessel. So I'll talk about the shock and all. Okay, let's finish these things. We'll come to that. Okay. Now look here. Alpha 1A is in the urinary bladder sphincter. Alpha 1B is located in the blood vessel. Now, if you block alpha 1B, it will decrease the BP. Okay. If you block alpha 1A, it will make the easy urination. So where you need to easy urinate the patient? In the patient with the BPH, benign prostatic hyperplasia. If I have a patient with the benign prostatic hyperplasia, I need to block alpha 1 receptor. Now listen to me, the drug which block the alpha 1 receptor, the name of the drug is your tamsulosin. What is that? Tamsulosin. Now, tamsulosin is a drug which will specifically block, what is that? Alpha 1A receptor. So, it will be used for the BPH. But if I ask you people, is it a drug of choice for BPH? No. This tamsulosin is the symptomatic symptomatic drug of choice. Symptomatic drug of choice for BPH means BPH patient will have a difficulty in urination. To improve that symptom, we are using tamsulosin. Please don't get confused. To just what? To improve the urination, to treat the symptom. Okay. If I ever ask you people the drug of choice for BPH, then your answer will be 5 alpha reductase inhibitor. 5 alpha reductase inhibitors such as finasteride, Okay, so this is a drug you need to remember. Now let's go to the next aspect. What is that? If I have a patient who is having benign prostatic hyperplasia along with that hypertension, so then what you need to do? All you need to do is that you need to look back here and understand. Look back here, you need to block alpha 1A and alpha 1B. So exactly we are going to use alpha 1A and alpha 1B blockers. Alpha 1A and alpha 1B blockers, which can also be called as alpha 1 antagonist. Alpha 1 antagonist. Okay, now alpha 1 antagonist, very good. You people already told me what is that? Prazosin, terazosin. So write down the names of the drugs. We have a drug called as terazosin. Okay, we have a drug called as alfuzosin. Okay, we have a drug called as prazosin. Okay, now among these things, what is the most important aspect? If I ever ask you the MCQ, BPH with hypertension, your drug of choice will be your, what is that? Drug of choice will be your, very good, that is alpha 1 antagonist such as terazosin, alfuzosin, doxazosin, prazosin. Okay, now you people will tell me which is that drug used for scorpion bite. Remember, prazosin is used for scorpion bite. So this is also an important aspect. If they want to ask you very easy question, sometimes yes, there are easy questions. They'll ask you what is the best drug used for the treatment of scorpion bite. The best drug would be your, what is that? Best drug would be your prazosin. So once we are finished with the prazosin, let's go to the next important aspect. What is that next important aspect? Side effects of alpha blockers. This has been a very trendy question. This was asked very repeatedly, more than 4 to 5 times in last 5 years, maybe last 5 years. Yeah, 5 years or 6 years. Okay, so in that I want you to understand. So alpha 1 receptor blockers, they will cause one side effect that is only called as first dose effect. What is that? First dose effect. Now, first dose effect, many people will get confused. Sir, what is this first dose effect? That first dose effect only what you know already. What is that? Very good. Orthostatic hypotension. What is this orthostatic hypotension story? That is basically a first dose effect which will cause the orthostatic hypotension. What is this orthostatic hypotension? This orthostatic hypotension, patient will be lying down, he will wake up and he will try to walk. When he tries to walk, all of a sudden venous return will decrease, which will lead to decrease of the BP, called as orthostatic hypotension. Usually orthostatic word, we are referring to the change of position. Okay, change of position will lead to decrease of the BP, and that can be observed even with the first dose of the tablet itself. See, remember this. So first dose of the tablet itself can yield this effect. That is why we are going to call it as a first dose effect. First dose effect is what? First dose effect is your orthostatic hypotension. Because why it occurs, I'll give a quick review. We are blocking alpha receptor. If we are blocking alpha receptor, there is no vasoconstriction. Upon when? Upon change of position. If there is no vasoconstriction upon change of position, then automatically it will lead to decrease of the venous return, which will lead to decrease of the blood pressure. So basically orthostatic hypotension develops as a result of which effect? Decreased venous return, as a result of which decrease of the BP. We call it as a orthostatic hypotension. Okay. Now, of course, venous return is not there. Blood is pooling where? In the veins. Done. Okay. Now, let's continue to the next important. So, we are blocking which receptor? Alpha receptor. There is one more side effect. If at all examiner want to put you in a trap, this effect can also be seen. That is only your retrograde ejaculation. Retrograde ejaculation. So retrograde ejaculation is also a very important side effect which can be seen as a result of your, what is that? Which can be seen as a result of your, very good, that is your alpha blockers. So once we understood about, see, these are the two important side effects. So the examiner can ask you like this: all of the following can be seen with alpha blocker except first dose effect, orthostatic hypotension, retrograde ejaculation, and for example some cataract he'll give. The answer will be cataract because all of the following except I have asked. All of the following except I have asked. Got the point? So the same thing only he can make it into three options here. So wherever we have a three option, automatically done, done, or done. What is that? There will be MCQ. Okay. Now let's go to the next. After you block alpha receptor, alpha 1 is blocked. Then we have alpha 2 blocker, alpha 2 blocker. Now alpha 2 blocker, we have a drug called as yohimbine. Yohimbine. Now yohimbine is not FDA approved. Not FDA approved. If it is not FDA approved, understand, which is not clinically used usually for the treatment, but there are other uses. Since it is a plant derivative, it is derivative of a plant called as yohimb plant. Yohimb plant. So this drug usually it is not FDA approved. So but off-label uses are there. Off-label uses such as erectile dysfunction. Okay. Even for the premature ejaculation, even as an antidepressant. Okay. Let's go to the next aspect. What is that? Alpha blocking is done. Let's go, sir. Then go and block the beta blockers. What is that? Beta blockers. Beta blockers. Now, beta blockers are very much important. Why? Because let's understand. First important, beta blockers. We have something called as prototype beta blocker. What is that? Prototype beta blocker. Now, my dear students, prototype beta blocker is what? Prototype beta blocker which will block beta 1 receptor and also beta 2 receptor. If any drug which has all the properties of that group, we are going to call it as a prototype drug. Now prototype drug MCQ trap will be put for you people from opioids, which I'll teach you people, don't worry. Okay, so what I'm trying to tell you, prototype drug beta 1 and beta 2 antagonist. Now prototype drug beta 1 and beta 2 antagonist, the drug we have here, what is the drug? The name of the drug is your propranolol. Propranolol. Okay, propranolol. Now propranolol is a prototype beta blocker. Now let's learn about the propranolol. First important, in one place only, let's learn the uses, okay, side effects and contraindications. So all these three are definitely very important. There can be MCQ from here, very important. Okay. Now, first important, if it is blocking the beta 1 receptor, if it is blocking the beta 1 receptor, we can use it in the treatment of arrhythmia. Arrhythmia. Okay, it is also used in the treatment of which arrhythmia? That is tachyarrhythmia, but that is not as so much important. Yes, which can also be used for the treatment of hypertension. That also you learn from the beta blockers. But my dear lovely students, remember some most very important uses which are very specific to propranolol. The first and most important use, it is used for the prophylaxis. What is it? Prophylaxis of which disorder? Prophylaxis of migraine. Prophylaxis of migraine. Okay. Now, migraine question has been asked repeatedly. They'll ask you all of the following are used for the migraine prophylaxis except the first drug I have taught you people. One of them is propranolol. Then apart from that, guys, it is also used in the hyperthyroidism. Hyperthyroidism. Apart from hyperthyroidism, it is also used for the essential tremors. It is also used for the essential tremors. Okay. Now, when you're talking about essential tremors, now essential tremors, guys, there is no fixed, there is no pathology which is organic pathology. You got the point? So, if you look from the brain till the muscles, everywhere, every nerve, every conduction, everything will remain normal. Still, patient will have the small tremors. We call it as a essential tremors, which is common in the young people. If I want to ask you an essential tremor question, all the complete examination, all the investigation, everything is normal in a young patient with what is that? With your effect of the tremors. Then we are going to call it as a essential tremor. Okay. Now, apart from that, it is also used for the treatment of something called as, what is that? Stage fright or a performance anxiety. Stage fright or a performance anxiety. What do we call it as? Performance anxiety. Performance anxiety. What do I mean by performance anxiety? Suddenly, if I ask you to go on a stage and address some 2000 people, you will not be able to do that because you'll start to develop severe palpitation and anxiety. To treat that also, propranolol is used. See, beta blocker, all the beta blockers are used in these two, but in other places, these are the very important uses. So definitely there can be a question, what is the drug of choice for any of these things they can ask you. So please pay attention. Now, side effect. Side effect is very easy. Look here. What he has to do? He was supposed to block beta 1, but he is also blocking beta 2. If I block beta 2 stimulation causing bronchodilation. If I block the beta 2, bronchoconstriction. Very good. Side effect will be bronchoconstriction. If side effect is bronchoconstriction, automatically it is contraindicated in asthma patient, and one more patient. Who is that? Of course, COPD patient. Okay. It will also cause, what is that? Vasoconstriction. Vasoconstriction. So if vasoconstriction is there, what will happen? You need to pay attention here. Consider this the hand, right? Now, I have a blood vessel which is coming to my hand. Now, if I cause the vasoconstriction of this blood vessel, what is going to happen? Vasoconstriction, no blood supply. If there is no blood supply, automatically what will happen? This area will suffer ischemia. So you need to understand. What is that? If at all, normally if there is a small vasoconstriction, no problem. But if I have already I have a disease in the blood vessel, to that I will cause extra vasoconstriction. That time there will be totally loss of blood supply, can lead to severe ischemia. So please understand, vasoconstriction, we avoid them in a condition called as peripheral vascular diseases. Peripheral vascular diseases such as, can anybody tell me some peripheral vascular diseases? Two peripheral vascular disease. Chalo batao. Tell me, let's see. Peripheral vascular diseases. Tell me. Burgess disease, very good. Takayasu arthritis, okay. Anything else? Two very important ones. Remember these two things. What are those two things? Atherosclerosis. Then there is one more thing you need to understand. Very good. That is Raynaud's syndrome. Okay, Raynaud's phenomenon and syndrome are little different. That's it. Okay. Now, this is the story of your propranolol. Will you answer? Yes, of course. So please don't make any mistakes. Let's go to the next aspect. What is that, sir? Sir, what is that? We have selective beta 1 agonist. Selective beta 1 agonist. Now here only you are going to face a lot of problem. They will tell selective. Immediately they will bring a side effect as bronchoconstriction. Sir, what is wrong with you people, you might ask? I will teach you people how to remember that very easily. Okay. Now, selective beta blockers. First, let's write down the names. Let's make it a simplified technique to remember. Then we will go for other things. Okay. Now, what is that to remember, sir? So, what is that? They have a drug. What is that? That is only called as atenolol. We have one more drug. That is your betoxolol. Okay. So, don't panic. This is very easy. I'll tell you how to remember. Just okay. Okay. Now, let's go to the next important. Sorry. Yeah. This is a beta 1 blocker. Antagonist. Okay. Now, let's continue. Bitoxolol. Then, apart from that, we have other drugs such as metoprolol. We have drugs such as metoprolol. Apart from that, betoxolol, metoprolol. Then we have other drugs such as Iver. What is that? Can anybody tell me? What is that? Esmolol. What is that? Esmolol. What is that? Esmolol. Okay. We have all these drugs. We have acebutolol. There are so many drugs. Now, apart from that, write one more drug here only. Nebivolol. Nebivolol. Okay. Now, let's go to the other side. Let's write down here. What is that? Let's write down timolol. What is that? Timolol. Okay. Apart from timolol, we have a drug such as sotalol. We have drugs such as sotalol. Okay. Now, sir, why am I writing these two things separately? Now, if you notice here, remember one thing. What is that? That is this is the technique. What is that? A to M. Any drug, if its name is starting from A to M, any drug, if it is starting from A to M, M for who? M for me, myself, who is that? Maruti. From A to M, if any drug's name is starting, all of them are a selective beta blocker. Which selective? Selective beta 1 blocker. But for this one exceptional case, what is that exception? That is exception is nebivolol. Nebivolol. Okay. Now, any drug which starts from N to Z, which is beta 1 blocker and also your beta 2 blocker. This is a technique to remember. Okay. So that is what pinodolol. Okay. So all these drugs, whatever comes after N, except for one drug, nebivolol, all of them will have a beta 2 blocking property. Will you remember that, guys? Done? From A to Dr. Maruti, M for Maruti. You can remember it like that. A to M. Who is that? What is that? Beta 1 blockers, except one case, nebivolol. Rest every other drug, beta blocker will come into. Any other drug which starts from N to Z, then we are going to call it as a non-selective property of a beta blocker. Easy to remember now? Now, so here only you can understand this betoxolol is used for glaucoma. And timolol also used for glaucoma. Betoxolol also used for glaucoma. Timolol also used for glaucoma. Now the next important aspect. What is that? Guys, esmolol. Esmolol is a shortest acting drug. That is your shortest acting drug. If any drug is shortest acting, automatically it will be fast acting. Shortest acting drug will be automatically fast acting. That is the story of your, what is that? Selective beta 1 antagonist. Now, when we need to understand about the next aspect, once we understood about the antagonist, let's understand the generalized uses of this beta blocker. What is that? Generalized uses of the beta blockers. So, understand what is that. The one of the most important aspect is that hypertension. Now, the MCQ here. What is the mechanism of beta blocker in treatment of hypertension? Okay, this will become a very important aspect. Okay, I will give you the option. Option A, they will decrease the heart rate. That is how that will lead to decrease of the BP. Option A. Option B, they will decrease the force of contraction. That will lead to decrease of the BP. Option C, they will decrease the renin release, which will lead to decrease of the BP. Option D, none of the above. Now, this is a very important MCQ. This MCQ was asked and can be asked again and again. Let's see, you people can answer it. Okay. So, one student of ours says A and S says C. Any other answers, please? Let's see. Tell me. Okay, A. I'm waiting. This one I want you people to see how much attention you have paid. Okay. Any other answers? Anybody who says none of the above? Okay. So the answer is, my dear students, when I say this kind of specifically, that is definitely what is that? trap. So answer is C. So those who marked answer is C as a correct answer. Remember, if beta 1 is blocked, the correct answer is if beta 1 is blocked, that will lead to decrease renin. Most importantly, pay attention to this particular word, renin release. Renin release. This is the most important mechanism through which BP will be decreased by beta blocker. This is a very important question to be remembered. Will you remember it now? Done? So understand, beta 1 blocker will decrease the renin release, which will decrease the blood pressure. This is a very important aspect. Okay. Why not A? I will tell you, heart rate if you decrease, that will not alter the BP significantly. Okay, that is not the reason. Second thing, if you decrease the force of contraction, still heart is pumping. Okay, it will not significantly decrease the BP. But if renin is decreased, automatically what will happen? BP will be decreased because RAS system is one of the major regulator of your blood pressure. Got the point? Got the point? Why not A? That is the reason. Okay. So always remember, this is an important aspect, and please, I am requesting everyone, please pay attention and learn here. Beta blockers decrease the renin release. They will not inhibit the renin. But they will inhibit the renin release. Repeat this and remember, because you might get confused. If you consider this is a blood vessel, and this is the story of your kidney. Okay, now understand, renin will be released into the blood vessel. If renin is already released inside the blood vessel, if you block this renin, that is done by with the drug called as aliskirin. Okay, now if you block here, what is that? Stop the release itself, then your beta blocker. Okay, if renin is already released, that will be inhibited by drugs such as aliskirin and primaskirin. But most importantly here, if renin has not released and we want to prevent its release, then you are using beta blocker. I'm telling again, beta blocker will prevent the renin release, because this is a standard confusion which can happen to any students. Clear, everybody? No, that is what plasma renin levels will not be directly lowered. Okay, see, plasma renin will be less when you use beta blocker, but not directly by inhibiting the release, because directly if they are decreasing the renin level, then you are aliskirin. If directly decreasing the renin level, aliskirin. Indirectly by inhibiting its release, beta blocker. Okay, so both the drugs will decrease the renin level, but one of them stops the release, that is beta blocker. Please, if I have told you this question this many times, definitely you need to understand the worth of this question, why I have been explaining. Okay, chalo, let's continue. What is that? Once we understood about the hypertension, let's go to the next aspect. What is that? They're used in the tachyarrhythmias. Tachyarrhythmias. So tachyarrhythmias such as atrial fibrillation. Even in some other cases of PSVT also we can consider beta blocker, but not the first line. Okay. Now tachycardia. Okay. Apart from that, they are used in the chronic heart failure, but absolutely contraindicated in acute heart failure. Pay attention to this. They are absolutely contraindicated. Okay, so what is that? They are absolutely contraindicated in which condition? Acute heart failure. We'll come to that. Very good. Angina also we are going to use them. Very good. Okay, so there are some non-shockable rhythms, we can consider them. Okay, but not every case. Okay, now look here. In the acute heart failure, if you give a beta blocker, patient might die because heart rate will suddenly go down. But chronic heart failure, why we are using them? In chronic heart failure, it will beta blockers will decrease the heart rate. If they are decreasing the heart rate, what will happen? My dear students, understand, if at all I have 60 beats per minute for one condition, 60 heartbeats, I have 120 heartbeats per 1 minute. Okay, now from one heartbeat to another heartbeat, which has lots of gap. See, one heartbeat, dub, then after 1 second, dub, then after 1 second, dub. That is what? 60 beats per minute. But here what will happen? Dub, 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 dub. What? In 120 beats per minute. Means if you decrease the heart rate, your heart will relax better. That means it will increase the duration of relaxation of the heart, called as diastole. What is that? It will decrease the heart rate. It will increase the duration of diastole. It will increase the duration of diastole. If we increase the duration of diastole, automatically, if your heart is relaxing better, it is getting filled better, so that heart can pump better. So that is what it will increase the filling. So this is the most important reason. See, other reasons, I'll tell you, other reasons also there, but most important reason is decrease the duration of diastole, but other reasons such as decrease the O2 demand can be considered. Okay. Now, the next important aspect. The next important aspect, my dear students, they are used in the angina patients. Angina patients. Angina patients, why? Because beta blockers decrease O2 demand of the heart. Here it is a specific reason. So O2 demand of the heart will be decreased. Then angina. Okay. Now apart from angina, these drugs also used in one condition which I taught you people already. Glaucoma. What is that? Glaucoma. In the glaucoma, two drugs. What is that? Betoxolol. Betoxolol. Then one more condition, one more drug. What is that? Timolol. Clear? Timolol. So timolol, can you use it in a patient with bronchial asthma? Can be used in asthma. True? False? B. Tell me. Option B and option A. One of them is true, one of them is false. Okay, some people says false. Okay, Rahman says false, rest other says nothing. Huh? False, false, false. Very good. The correct answer is false. So, why correct answer is false? Because timolol, yes, of course, when you put it in the eye, you might be thinking, sir, we put it in the eye, drug is in the eye, what is the problem? The problem is that from the eye, the drug will go into nasolacrimal duct and it will go into the systemic circulation, causing bronchoconstriction. So, please avoid timolol in a patient with bronchial asthma. Very good. Okay, so these are the some important uses of your beta blockers. These are some important uses of beta blockers with every use as mentioned as MCQ. Clear, everybody? Clear? Able to follow me? So today I hope there are no issues for you people related to voice breaking, cut down, nothing. Let me look at your comments first. Able to follow me so far? Able to understand everything? All right, very great. Perfect. Then let's go. Let's go to the next aspect. So we are done with the autonomic nervous system, but we are left out with one particular aspect. Sir, we blocked alpha receptor, we blocked beta receptor. So anywhere if we are specifically blocking, there should be someone who blocks non-specifically also. Means what? Alpha plus beta blocker. Write down alpha plus beta antagonist. Beta antagonist. Alpha plus beta antagonist. We have two drugs, my dear students. So these two drugs are your carvedilol. Carvedilol. There is one more drug called as labetalol. Labetalol. Okay. Now, what about these two drugs? My dear students, these drugs also again they're used for hypertension. Used for hypertension. But remember, the most important, labetalol is the drug of choice for pregnancy hypertension. So any female with a pregnancy induced, which is called as PIH, pregnancy induced hypertension, the best drug you can give is labet. What is it? Labetalol. So two drugs we learned about safe in pregnancy so far for the hypertension. What is that? Very good. There are alpha methyl dopa and labetalol. Got it, everybody? Okay. Hope everybody understood this. Let's go to the next aspect. What is that? That is your, once we are done with your autonomic nervous system, we are getting into the next and most important aspect, central nervous system. Okay, so when we need to understand about central nervous system, so very easy, very simple life, but only thing is that lots of drugs, lots to remember. I'll make it simplified. So in every topic here also, again, I'll be highlighting here, there will be many concepts are simple, but the questions are to be remembered. The question oriented points are to be remembered. So I want you people to pay attention. When I ask you to repeat, do it with me right now so that you don't have to do it later on in your preparation. Okay, so let's start with the central nervous system. Okay, now listen to me very carefully. Central nervous system. In the central nervous system, let's start with one of the most commonly used drugs, one of the commonest disorders. Let's start with the anti-Parkinson drugs. Anti-Parkinson drugs. My dear students, anti-Parkinson drugs, if you need to understand what exactly happens in the Parkinson disease. So Parkinson disease, what happens is that decrease of the dopamine. Decrease of the dopamine in which area? In an area called as substantia nigra. Substantia nigra. It is a dark area which is present in the brain, especially in which part of the brain? Called as basal ganglia. Basal ganglion. Now, substantia nigra is a part of basal ganglion in which what happened? Decrease of the dopamine. Okay. Now, if you need to understand this, what we need to do? Sir, what we need to do is that consider this is one neuron. This is one neuron. There is one more neuron. Okay. Now, this neuron will produce your what is that? Dopamine. Now, dopamine usually acts upon what? Dopamine receptors. All of us know that. Dopamine receptor. Now, what exactly we need to learn? Sir, what you need to learn here is that either you can increase the dopamine, yes, we can treat it, or directly stimulate the receptor, we can treat it. So, there are two ways, either increase the dopamine and treat the Parkinson, or one more way is what? One more way is that is your very simple way, directly stimulate the dopamine receptor. Okay, now let's understand. Guys, about acetylcholine. So let me tell you people, acetylcholine is balance of the neurotransmitter. What do I mean by balance of the neurotransmitter? That balance is like this. Consider this is your acetylcholine, this is your dopamine. Once dopamine level is low, acetylcholine will look like it is elevated. So what you have to do is that maintain those levels equally. Maintain those levels equally. Okay, so this is the most important aspect you need to understand. Okay, now guys, if you need to understand about this, it's very easy. So what exactly we need to do? First, what I did, I gave a dopamine. I gave a dopamine. How did I give? IV. I gave what? IV dopamine. IV dopamine went to where? To a place called as blood-brain barrier. To a place called as blood-brain barrier. Now, in the blood-brain barrier, this dopamine was not able to cross the blood-brain. Dopamine was not able to cross the blood-brain barrier. If dopamine was not able to cross the blood-brain barrier, I developed a drug. What is that? Levodopa. What is that? Levodopa. Now, I developed a levodopa. Now, this levodopa can cross the blood-brain barrier easily. Okay, now levodopa will cross the blood-brain barrier. Now there is under the influence of one enzyme called as dopa decarboxylase. Dopa decarboxylase. Dopa decarboxylase. It will get converted into dopamine. It will get converted into dopamine. Okay, so one problem is sorted. One problem is sorted. Okay, now, let's go to the next important. But the problem is that, guys, when I use this levodopa, now in the periphery also, I will have the same enzyme, dopa decarboxylase. Now, dopa decarboxylase will convert the levodopa into dopamine. Levodopa into dopamine. Now, this dopamine cannot cross the blood-brain barrier. So if I want to make my levodopa to reach the central nervous system, the first thing I have to do is that I need to block this. If I block this dopa decarboxylase, levodopa will increase, automatically it will cross the blood-brain barrier. So for that purpose only, peripheral dopa decarboxylase inhibitor, we have a drug called as carbidopa. Carbidopa. Now what is carbidopa's mechanism of action? Okay, yeah, of course. We will come to that. Okay. Now, Now, carbidopa. Now, this carbidopa is an important aspect. Why? Because see, levodopa is not crossing the blood-brain barrier because it was getting converted into dopamine. So he took a help of his friend. Who was that? That was your carbidopa. So first important mechanism of action of carbidopa. Carbidopa. The mechanism of action of carbidopa, it will inhibit dopa decarboxylase. My question is that will it cross the blood-brain barrier? Cross the blood-brain barrier. Okay, tell me, let's see. We will come to that CTZ. Now, I'll come to the story of complete dopamine in the CNS when I'm teaching antipsychotic drugs, okay? With the pleasure, I will teach you people how pleasure also plays a role with dopamine. So, we need to apply our common sense. What is that common sense? If carbidopa goes to central nervous system also dopa decarboxylase will be inhibited. So, please understand, no crossing of the blood-brain barrier. So, carbidopa, no sir, no crossing of the blood-brain barrier. Wow, very nice. Okay. Now, let's go to the next important aspect. Now, dopamine came to the CNS. Now, understand this is your blood-brain barrier. Okay. This is your blood-brain barrier. Now, here is your brain. Inside the brain, what goes on? Let's see. Let's consider this is one dopaminergic neuron. Let's consider this is one dopaminergic neuron. So, this dopaminergic neuron will have all the drugs working in one place only. Look here. So, what do I have? I have dopamine receptor. Usually in the brain, which are those there? They are your D1 or D2 receptor. D2 receptors are located in the brain usually. Okay. Now, look here. Dopamine will be released. Dopamine will be released, or maybe from your levodopa you might have got the dopamine. Levodopa you got the dopamine. Now this dopamine, what happens is that it will go and act on the D2 receptor. Now the issue is that this dopamine can be metabolized by two enzymes. Dopamine can be metabolized by two enzymes. One of them is called as monoamino oxidase B. Monoamino oxidase B. Okay, then there is one more enzyme called as COMT. COMT. These both will metabolize dopamine into its degradation products. Now, what I can do if I inhibit MAO-B, if I inhibit MAO-B, automatically that will increase the dopamine. That will increase the dopamine. What are the drugs? MAO-B inhibitors. Let's see. So, MAO-B inhibitors, we have, what is that? That is your, yes, you are correct, Rahman. Let's come to that one by one, okay? MAO-B inhibitors, we have drugs such as selagelin. What is that? Selagelin, okay? Selagelin. There is one more drug called as rasagelin. What is that? Rasagelin. Rasagelin and selagelin are MAO-B inhibitors. What is that? MAO-B inhibitors. Then we have one more drug. What is that? If I inhibit COMT, they will also lead to increase of dopamine. They will also lead to increase of the dopamine. What are the drugs we have? We have entacapone. Then we have one more drug. What is that one more drug? So entacapone, as you told, we have one more drug, that is your tolcapone. What is that? Tolcapone. What is that? Tolcapone. These are the two drugs. So let me look at the comments. So not lipid soluble, no hepatotoxicity, so COMT. Yes, of course, COMT blockers are your, what is that? COMT blocker is a tolcapone and entacapone. Now, please understand, these drugs are also used for the Parkinson disease. My dear students, I want you to understand one more thing. What is that next one more thing? See, what exactly is that? That is your, we have a drug called as amantadine. Amantadine. Now this amantadine is a type of antiviral drug. It is a type of antiviral drug. Though it is a type of antiviral drug, this amantadine increase the dopamine availability. Increase the dopamine availability. Okay. Availability, if that is increasing the availability, that can also be used. That also shows the effect. So they might ask you, these are very simple drugs. Amantadine is used for, what is that? Antiviral, and as well as your dopamine availability increase. So Parkinson disease. Apart from that, the last thing what you can do, my dear student, D2 agonist is there, na? Directly we can stimulate the D2 receptor. Directly we can stimulate the D2 receptor. If directly we are stimulating the D2 receptor, so basically you are focusing on one thing. What is that? That is dopamine agonist. Dopamine agonist. Now dopamine agonist, my dear students, what are the drugs we have? So the dopamine agonist, we have drug called as bromocriptine. Bromocriptine. What is that? Bromocriptine. Apart from bromocriptine, we have one more drug that is called as cabergoline. Cabergoline. What is that? Cabergoline. There is one more drug. What is that? Very good. Very good. Pergolide. What is that? Pergolide. What is that? Pergolide. Then we have one more drug that is only called as pamipexole. What is that? Pamipexole. Pamipexole. Okay. Now there is one more drug called as ropinirole. Please don't get too much into your what is that? That is your confusion. I'll tell you what are the things to be remembered. There is one more drug called as ropinirole. Ropinirole. But among all these things, remember one of the most important, bromocriptine. Bromocriptine is a very important drug, not for its use in the Parkinson, but also its other uses. And there is one important aspect, that is, you are write down here, new transdermal patch. New transdermal patch available for the treatment of the Parkinson disease is called as rotigotine. Now this rotigotine, my dear student, it is a type of non-ergot drug. Now this non-ergot drug used in the form of a transdermal patch. This is a MCQ here. So which anti-Parkinson drug which is used in the form of a patch form which is available in the market today, that is your rotigotine, which is a non-ergot derivative. Now bromocriptine, other uses, write down. Bromocriptine can be used for the treatment of diabetes mellitus. Bromocriptine can be used for the treatment of diabetes mellitus. Apart from the treatment of diabetes mellitus, now cabergoline, now listen to me very carefully. Bromocriptine and cabergoline both are used for prolactinoma, but the best one for the treatment of prolactinoma is cabergoline. Why? Because cabergoline is a longer acting drug. So please don't get confused. Prolactinemia, we are going to use what is that? Bromocriptine and cabergoline, but the best drug is your cabergoline. Now pamipexole and ropinirole are recently better used compared to the other drugs. This is the story of your Parkinson drugs. Drugs. Clear, everybody? All right. So once you understood about the Parkinson drugs, then we are going to the next important aspect. That next important aspect, what we will be studying, that we will be starting with your opioids. So before starting opioids, let's take a small break of few minutes, some about 10 minutes, and we will be back. Approximately a break of 10 minutes. All right. How to be consistent. So I'll give the solution for how to be consistent. And before going to Swapnil Upadhyay's comment, let's go to the previous comment. Sir, what about antimuscarinic usage in Parkinson to minimize the symptom of ACH? We will talk about it right now. Okay. Now we'll talk about it. Before going there, as you asked, how to be consistent? Very simple. The first rule to be consistent is that you need to determine what is your target. The target is to achieve the exam. Understand, very simple thing. So studying 200 textbooks right now is not going to help you. Studying concisely is going to help you. Okay. So first set a target. The target is what? Exam. Okay. Now, after you set a target, what you need to do? So what you need to do is that first few days you'll feel a difficulty to start studying, or to focus yourself, or deviations. Okay. So please understand, I'm going to tell you something very, very root level way. Okay. So consider you have a problem, financial problem. Consider. Okay. If you have a financial problem, till the day of exam, the problem will be there. After the exam also, the problem is going to be there. Yes, it will be provided. After the exam also, the problem will be there. Okay. So what you need to understand, to To solve that problem, you need to have something in your hand, so better go for the exam. So what I'm trying to tell you is that, see, there might be some problem which will be there before the exam also, after the exam also, but the point of the exam will not change. So understand that particular aspect, because you need to prioritize. Your most important priority is to pass the exam. To pass that, the next important key is that you need to be consistent. How to be consistent? You need to determine the target. After you determine the target, what you need to do? The first thing is that, okay, screw every problem in this world. I don't have anything to do with those. My main target is exam. So accept that. Accept that first. To accept that, you'll take time. Not immediately, like I'll close my eyes and I'll tell, okay. No, that is not a technique, okay? What you need to do, take a time of maybe half day, 1 day. So think about everything. At the end of the day, the major problem will be in front of your eyes is exam. So always focus on immediate problem in front of your eyes. That is your target. So please focus on that particular aspect and go accordingly. The next thing you need to do is that to become consistent. The first few days when you are studying, it will be very difficult. I'll sit in front of a notes and I'll be like, after 2 pages, I'm not able to read. So to overcome that technique, make a timeline of this one. 45 minutes. 45 minutes. Okay. So study for 45 minutes. While you are studying for 45 minutes, don't think about anything. After 45 minutes, you can think about all of your any problem, your girlfriend issue, boyfriend issue, whatever you have, you can think about it. But during those 45 minutes, exclusively focus on study. After 45 minutes, you do whatever you want. Take break. Again, go for 45. So this 45 minutes, why am I telling you people? Because this 45 minutes is an important key factor, because human usually able to focus about 40 to 45 minutes. Utilize that time, immediately take a break. You pay your attention to anything you want, then immediately come back to this. Okay. And one more thing, don't do this preparation of 6 hours straight. Sir, I will sit now and 6 hours straight, I'll sit and study. No, that is not a good idea. What you need to do, you need to divide the timeline. How you need to divide? First, for example, morning you take up your 2 hours of time. Okay. Afternoon you take out of your about 3 to 4 hours of time. Okay. For example, evening. Okay. How you need to take out that? For example, morning before the class, you had some time, go for it. Then next afternoon, you don't have class, do it. Then later come back in the evening and study. So that's how you need to manage. So if you consistently, along with whatever preparation you are doing, apart from the preparation means whatever notes you are studying, apart from that, for your main revision, if you give 6 hours a day, definitely you'll pass, my dear. Okay. That is an important aspect. But without doing that, don't run for the run for the 6 hours. I'll sit and read for 18 hours straight. In 18 hours straight, you'll remember 18 minutes of what you studied. Okay. Rather than that, 1 hour I'll study, I'll take a break. 1 hour I'll study, take a break. 1 hour I'll study, take a break. This will improvise your efficiency like anything. Got it? Okay. So we will come back to our Parkinson. So in Parkinson, what I was discussing to you people about all the drugs used in the Parkinsonism, but let's talk about one important small aspect here, that is your drug-induced Parkinsonism. Drug-induced Parkinsonism. So drug-induced Parkinsonism. Now, this drug-induced Parkinsonism is a very important, because see, we are treating the patient by giving some medication, and those medication will trigger the Parkinson disease. The most important drugs are your antipsychotics. Antipsychotics. Okay. So drug-induced Parkinsonism, what is the cause? One of the important causes antipsychotic drug. Okay. The next important thing, what you need to do? The next important thing, the treatment for the drug-induced Parkinsonism. So the treatment for the drug-induced Parkinsonism is very easy, sir. What is the treatment? The treatment will be your, for example, we have drugs such as benztropine. Okay. Then we have one more drug that is only called as trihexyphenidyl. So these are the 2 drugs which are used for drug-induced Parkinson. Done? Okay. Now let's go to the next aspect. We are done with what is that? Drug-induced Parkinson. Guys, wake up and listen to this most interesting aspect. What is that? Opioids. Now, when you are understanding about opioids, okay, now opioids are one of the most important aspect. What is that most important aspect? Opioids are derived from a plant. Okay, so we will provide how to contact me, don't worry. Okay,
Now, first important aspect, opioids. Now, opioids, my dear students, opioids are first naturally derived from the opium plant or a opium plant. Opium plant derived alkaloids. Opium plant derived alkaloids. Okay. Now, these are the opium plant derived alkaloids. Okay. Now, this opium plant or which is also called as a poppy plant, which is also called as poppy plant. So, you might be thinking, what is poppy? You remember that poppy seeds which used to put in the delicacy of sweets, in all the sweets made all over India, we use these poppy seeds, the white color small seeds. So, in many places, it's called as cuscus. That plant itself will produce some alkaloids. They are called as opioids. From there we started to develop the newer drugs and we started to put them into the uses. So first and most important, opioid drugs. Opioids, usually they are opioid agonist. Opioid agonist. What do I mean by opioid agonist? That means they are going to stimulate the opioid receptor. If they are opioid agonist, my dear students, please understand, they are opioid agonist, agreed. So they are going to stimulate opioid receptor. They are called as mu, kappa and delta. Mu, kappa and delta. So these are the three receptors which will get stimulated by the opioids. So if these three receptors are there, the effects on the body, it is very important. Effects on the body. What are the effects on the body? Whenever you use a opioid, these are the effects which you are going to get. The first most important effects, write down, those are called as physical dependence, physical dependence, physical dependence. Okay, then there will be one more effect that is only called as meiosis. Meiosis means what? Narrowing of the pupil. So opioid overdose patient will come with narrowed pupil, narrowed pupil. Okay, then there is something called as cough suppression, cough suppression, cough suppression. Okay, then then there is one more effect called as analgesia. What is that? Analgesia. Analgesia means that is to decrease the pain, to decrease the pain. Okay, then there is one more thing, that is only your respiratory suppression, respiratory suppression. Now respiratory suppression and cough suppression might sound same way. For cough suppression, you need to remember one important aspect, that is there is a drug, that is your codeine. We'll come to that. But apart from that, there is one more thing for which people are taking IV opioids and people are getting addicted. That is only your euphoria. What is that? Euphoria. After euphoria, patient will get the sedation. What is that? Sedation. So how to remember the effects of opioids? With the help of a mnemonic. So what you need to do, just highlight the first letters, P, M, C, A, R, E, S, called as PM cares. PM cares. So these are the effects. PM cares is the effects which we are going to get as a result of opioids. For C, you can put one more effect here. They will also cause, my dear students, constipation. What is that? Constipation. What is that? Constipation. So these are the these are the effects which you are going to get as a result of your opioids, as a result of your opioids. Okay. Now, so all the drugs which you have opioids, which I am going to use in the clinical practice, about we are going to use these effects. There is there is one thing I want to finish it off here only. For the cough suppression, what is that? Codeine. What is that? Codeine. Codeine is a drug which was used for the dry cough, which was used for the dry cough. Today's timing, in today's reality, we are not going to use your, what is that? Codeine. Codeine is not used because of its excessive addiction property. And where did I teach about codeine yesterday? Please tell me. Let's see. Let me look at the comments. I want you people to answer. Where did I teach about codeine yesterday? See, dry cough, we have opioid analog, we have dextromethorphan, which we are using right now. But codeine, I want you people to answer. I told you people about codeine, some one particular aspect about codeine. Codeine, in biotransformation, codeine will get converted. So codeine is an active drug which will give rise to an active metabolite called as morphine. Active drug to active metabolite. Active drug to, it's all right now. Remember, active drug to active metabolite which will be converted from the codeine, that is your morphine. Morphine is the active metabolite of codeine, which is having excessive addiction property, which we don't use it in the clinical practice anymore. Let's continue to the next important. We have drugs. The first important aspect, opioid agonist. Opioid agonist. We have drugs such as morphine, We have drugs such as morphine. Okay. We have drugs such as fentanyl. We have drugs such as fentanyl. Apart from morphine and fentanyl, is there anything else? Yes, there are other drugs also. Other drugs also, such as pentazocaine. Pentazocaine. Okay. Then you're also having, what is that? You're also having one of the most important aspect, that is your, what is that, my dear students? That is your, what is that? Your codeine. Codeine also falls into the same class. But why am I writing this? Please remember, morphine is a type of prototype opioid. What is that? Prototype drug. Prototype drug means what? It will stimulate. It will stimulate, of course, all the three receptor, mu, kappa, and of course your delta. So if you are stimulating all these three receptors, we are going to call it as, what is that? Prototype opioid. So prototype opioid, if I ask you people, the most important answer is your morphine. The next important question, which was frequently asked just because of this reason only. So the next question is that fentanyl. Fentanyl is a type of synthetic opioid. Fentanyl is a type of synthetic opioid. And remember, fentanyl is available in the form of a patch, available in the form of a transdermal patch. And the most important question, this is the most potent. This is the most potent opioid, So this is a very important question to be remembered. What is that? That is your, please remember, that is your most potent opioid. That is your fentanyl. The question was asked at least 4 times in last 2 to 3 years itself. So please remember this particular aspect. Morphine is a prototype, fentanyl is a synthetic and very strong. Apart from that, we have one more drug, that is your meperidine. Agreed with you. Let's go to the next important. Agonist uses. Where do we use these drugs? So uses are very important. So my dear students, the first and most important use of these drugs for the pain management. For what? Pain management. What is that? Pain management. Okay. Sir, pain management, what you are trying to tell us? So for the pain management of such as trauma, if a patient with trauma, we can use them. Patient with a myocardial infarction, we can use these drugs for the pain management. Not drug of choice, but for the pain management. Okay. Now remember, these drugs also used in the pulmonary edema. Also used, but not a drug of choice. Yes, they are used in the pulmonary edema. Remember, especially which drug, if I ask you people, able to understand morphine, you need to be able to tell the answer. So morphine is better used for what? Used for the pulmonary edema. Okay. Apart from that, my dear students, these ones are also used for the surgeries. Okay. During the surgery for the analgesia, we can use this drug. Apart from that, there is one important aspect. What is that? These can be used for the painless labor. So there is some techniques which we are doing these days. What is that? Without pain, we are trying to deliver the baby. For that painless labor, we can use it. We can use this drug. But if they are used, they can cause prolongation of which stage of labor? Anybody tell me? Prolongation of which stage of labor? Tell me, how many stages of labor are there? How many stages of labor are there, and prolongation of which stage? How many stages of labor are there? So there are 4 stages of labor. In that 4 stages of labor, which stage will be prolonged? It is lead to the prolongation of second stage of labor. Second stage of labor. Very good. Total 4 stages. According to WHO, after delivery of the placenta, sometime monitoring is there. 4 stages should be there. Okay. So it will prolong the second stage of labor. This can be an MCQ which can be asked. So be prepared. Now, next important aspect. So apart from this, for any pain management such as cancer-induced pain, for all those cases, we are going to use the opioid agonist. Now, we have one more thing. They are called as mixed agonist and antagonist. Mixed agonist and antagonist. Now, what is this mixed agonist and antagonist? Now, please understand mixed agonist and antagonist. So, we have mu receptor, kappa receptor, delta receptor. In one location, it will be agonist, means in one receptor. For example, it is agonist to mu receptor, but it will be antagonist to, which will be antagonist to other kappa and delta receptor. Like that kind of action, mixed action will be there. So the drugs are there. There are drugs. One of the most important drug you need to remember. What is that? Buprenorphine. What is that? Buprenorphine. This is a very important aspect. This is a very important aspect. And again, you are going to write one more drug. It is pentazokine. So pentazokine, you people might have studied there also, but here also pentazokine having a major activity, that is mixed activity is there. Okay, so please understand. Okay, now please listen to me very carefully. These drugs, where do we use these drugs? Where do we use this drug? They are again used for the pain management. Okay, now there is one confusion. Sir, buprenorphine, can we use it in smoking cessation? No, sir. It is a bupropion. Bupropion is used for smoking cessation. Okay. Then let's go to the next important aspect. We have one drug. There we have one drug, that is methadone. That is methadone, my dear students. Methadone is a opioid used for treatment of opioid addiction. What is that? Opioid addiction. Opioid addiction. Okay, remember, opioid addiction treatment, we are going to use a drug methadone. Okay, now let's go to the next aspect. What is that next aspect? So the next important aspect, apart from methadone, we are going to go to the next important aspect, that is opioid antagonist. What is that? Opioid antagonist. What are opioid antagonists? Opioid antagonist is nothing but they're going to block the opioid receptors. So opioid antagonist, we have drugs such as naloxone, and we have one more drug called as naltrexone. What is that? Naltrexone. So we have two drugs, naloxone and naltrexone. These are the opioid antagonists. What are the uses of these drugs? Uses of this drug, they are used as an antidote. See, antidote for opioid overdose. Okay, so for the opioid overdose treatment, we are going to use this drug, especially which drug? Now I will tell you people, please listen to me. First thing, opioid overdose, what are the clinical features? Okay, tell me the clinical features of a opioid overdose. The opioid overdose, there is a decreased respiratory rate, then there is a meiosis, that is constriction of the pupil. It can go even to a level of pinpoint pupil. Okay, then the next important symptoms which can be present, that will be your loss of consciousness. So opioid overdose treatment, IV, what is that? IV naloxone. Why IV naloxone? Because it is a short acting drug, and it is a fastest acting drug. So you need to understand and remember. Apart from that, naltrexone is used for the opioid addiction management. What is it? Opioid addiction management. That is especially which drug? Naltrexone, which is also available in the form of a tablets. Okay, so among this, what are the three important things I want you to remember? These three things, if you know, definitely one of the question will be from here only. Which is the most potent opioid? Fentanyl. Which is the prototype opioid? Which is that? That will be your morphine. Then which drug is used for the opioid withdrawal management? Opioid withdrawal long-term management, we are going to use best drug is methadone. Apart from methadone, we can use naltrexone. And opioid overdose treatment will be naloxone, which is IV naloxone. So the question will be, what is the antidote for opioid overdose? Or they can ask you people, opioid drugs are agonist or antagonist? Because opioid drugs are opioid receptor agonist, the treatment will be opioid antagonist. So this might confuse you people, because all of us studied opioids, so that will confuse. That is why examiner will put a trap for us. So what we need to do, my dear students, opioids are opioid agonist, that overdose treatment is antagonist. Will you be able to solve all this? Everybody clear so far? Okay, now once you understood about opioids, then let's continue to the next aspect. What is that next aspect? So let's go to the next important aspect, my dear students. They are called as antipsychotics. Now when you want to learn about antipsychotics, see, alcohol dependence, yes, we can use them, but there is other steps of management in alcohol dependence, but we can use opioid antagonists. That is not a main antidote, guys. This is not a main antidote. Antipsychotics. Now, when I want to teach you people about antipsychotics, okay. Now, antipsychotics is a easier topic for you to understand, easy to learn. So, look and understand what is antipsychotic drugs. Now, during this thing, you need to understand one of the most important aspect. What is that? What is a psychosis? What is a neurosis? What is a neurosis? What is psychosis? What is neurosis? Tell me. Some people will tell psychosis zyada pagal, neurosis kam pagal. Don't tell me this type of, okay. So what is the difference between a psychosis and neurosis? In both of these people, psychomotor agitation will be there, but one important aspect, that is about insight. What is that? Insight. Insight means what? If you tell the person that you are having some mental instability, he is ready to listen to the person that he is having some mental instability. If I tell you, okay, you have some mental instability, so you need to get treatment. That means if he is able to understand, that is called insight. Insight is present in the neurosis. Insight is absent in the psychosis. Insight is absent in the psychosis. Okay, very good, very good, very good, very good. Okay, now the next important aspect, there is a theory that for the psychosis, what is that? There is an increased level of dopamine, that is a theory. Increased dopamine can be present in the psychosis, that is a theory. So for that only, we are going to use your antipsychotic drugs. Antipsychotic drugs are divided into two types. What are those antipsychotic drugs? Usually, see, if dopamine is more, what we need to do, the target for us is that to block the dopamine receptor. That was the target. To block the dopamine receptor. That is the target. So if you want to block the dopamine receptors, let's see what you can do. So we have two types of antipsychotic drugs. What are the two types? We have something called as typical antipsychotic drugs. Typical antipsychotic drugs. Then we have one more thing called as atypical antipsychotic drug. Okay. Now understand atypical and typical. Atypical and typical. Atypical antipsychotics are the old drugs. Atypical are the newer drugs. So typical antipsychotics, they block the dopamine receptor. They block the D2 receptor. Along with that, they block the muscarinic receptor. They block the histamine receptor. They block even alpha adrenoreceptors. So when you notice here, are they very much specific? No, they are not specific to the D2 receptor. They are very much non-specific, and they will have a other effects as a result of muscarinic, histamine and alpha receptor. So wide range of inhibition was there. So to overcome that, we are developing newer drugs which are specific, but are they selective? They are less they're selective, but they're having less side effect compared to that of old ones. They usually typically block which receptor? They usually typically block D2 receptor. Along with that, they can also affect 5-HT, that is serotonin receptor. Okay, so what are the drugs we have? The drugs we have are, tell me, let's see, typical antipsychotics. How many of you can tell me? We have a drug called as chlorpromazine. Chlorpromazine. Okay. Then apart from chlorpromazine, is there anything else? Yes, we have one more drug. That is not a typical. So we have something called as haloperidol, my dear students. What is that? Haloperidol. Okay, we have one more drug called as droperidol. Okay, so all these drugs, okay. So we have one more drug, that is thiaridazine. So all these drugs are old antipsychotic drugs. Okay, there is a big list, among which I want you people to remember which are those. I want you to remember chlorpromazine. What is that? Chlorpromazine. Now chlorpromazine is what? Chlorpromazine causes one side effect, that is cholestatic jaundice. Cholestatic jaundice. This is a very important side effect. You need to remember. This can be asked as a MCQ. Okay. Now, apart from that, the next important aspect, see, look here, typical antipsychotics. We have a drug called as clozapine. Okay. We have a drug called as olanzapine. olanzapine. Now all these drugs, you need to remember every drugs, everything. No, there are some specific things which you need to remember and it will be done. Okay. So we are doing a review. We do it like a review only. Okay. Olanzapine. Apart from that, we have one more drug, that is quetiapine. Quetiapine. Okay. Now all these drugs, what are those drugs? These drugs are atypical. These are newer drug. We have one more drug called as risperidone. Okay. Now, my dear students, where do we use them? What are the uses of the antipsychotics? All of us know that uses of the antipsychotics, they are used in schizophrenia, psychomotor agitation. Okay, all the psychiatric positive symptom patients, we are going to use them for the positive symptoms. Okay, but the thing is that I want you people to focus here. They will not ask you the use, they will ask you the MCQs. So what are those MCQs? Look here, very easy. The first and most important aspect, what is the best drug of choice for your resistant schizophrenia? Resistant schizophrenia. Resistant schizophrenia. The resistant schizophrenia, the best drug of choice, what you can give? Yes, tell me, let's see. Let's see. What is a drug of choice for resistant schizophrenia? The drug is your clozapine. The drug is your clozapine. Okay, the drug is your clozapine. Okay. Now remember, my dear students, the side effect wet pillow syndrome. Wet pillow syndrome. What is that? Wet pillow syndrome. Basically, there is the patient will take the tablet, he'll sleep, the patient will have excessive salivation, because of which what will happen? Pillow will become wet, called as wet pillow syndrome. It is also caused by your one drug called as clozapine. What is that? Clozapine. Again, remember, it is due to 5-HT action, that is serotoninergic action. There is one more thing. Which drug has a anti-suicidal property compared to the other drug? Anti-suicidal tendency, anti-suicidal property. Anti-suicidal property is possessed by your clozapine. Okay. Apart from the anti-suicidal property and all these things, for example, if a patient, pregnant female with psychosis, what is the drug of choice? Pregnant female with the psychosis, the drug of choice is olanzapine. What is that? Olanzapine. What is the name of the drug? Olanzapine, my dear. What is that? Olanzapine. It is a safe drug. What is that? Safe drug. Okay. Now, apart from that, the cataract is a side effect. What is that? Cataract. Okay. Now, I'm talking about MCQs related to side effect. Cataract. Then there is one more thing. Cholestatic jaundice. Cholestatic jaundice. Okay. Then there is one more side effect. That is most deadly one. That is only your egg granulocytosis. Egg granulocytosis. So these are the side effects caused by who? What is that? Which drug? Okay. Okay, let's see what is the question. Did tetracycline can be used in pediatric therapy for diarrhea? Okay, cholera. My dear student, listen to me very carefully. Tetracyclines are absolutely contraindicated in children. Please do not use tetracycline in children. Okay. Let's go to the next important aspect. What is that? That is your agranulocytosis. So these three side effects. Cataract is caused by quetiapine. Quetiapine. Okay. Now, cholestatic jaundice is caused by chlorpromazine. Okay. Agranulocytosis is caused by clozapine. Not clonazepam, clozapine. Okay. Cholestatic jaundice, chlorpromazine. So these are the most important MCQs you need to remember from the antipsychotic drugs. And most important, pregnant female, that your drug of choice is olanzapine, and here wet pillow syndrome is caused by clozapine, and rest other uses of the antipsychotics you already know it. Okay. So once we are done with the antipsychotic drugs, let's go to your mood stabilizers. Now, what are these mood stabilizers? So, mood stabilizers, most important mood stabilizers are your lithium salts. Lithium. Okay. So, what are the drugs we have? Such as lithium citrate, for example. We have lithium citrate. Now, these lithium citrate mood stabilizers, where do we use them? The uses are your bipolar disorder. The most important use for the lithium salts is bipolar disorder. Apart from that, we can also use them in acute mania. Acute mania. So in both of these conditions, we can use this drug. What is that? Bipolar disorder and acute mania. We can use which drug, my dear students? Lithium. What is that? Lithium. Now, what is the important aspect for us doctors to remember? That is side effects. The side effects are most important one. They can cause ECG changes. Lithium can cause what? ECG changes. Okay. Apart from that, okay, during COVID, the one drug which could have caused ECG changes and widely used, which was that? Let's see. Tell me. The drug which was used during the COVID pandemic, but it could cause ECG changes. Which drug was that? Hydroxychloroquine, doctors. What is that? Hydroxychloroquine, which would cause a severe ECG changes. Okay. Now, listen to me. ECG changes. Apart from that, it is a type of teratogenic. But the most important thing they will ask you as a MCQ is that lithium is toxic to the kidney. What is that? Toxic. Very good age. That is hydroxychloroquine. Okay. Now, teratogenic, but the most important aspect, they will cause nephrogenic diabetes insipidus. Lithium can lead to nephrogenic diabetes insipidus. For that treatment is a drug called as amyloid. Amyloid is a drug which is used for the treatment of your nephrogenic diabetes insipidus caused by lithium induced one. Okay. Now, most importantly, when you give a lithium, you need to do one important aspect, that is only your TDM. We need to do what? TDM. What you need to do? TDM. What is TDM? You need to do therapeutic drug monitoring. So therapeutic drug monitoring to be done for the lithium. Okay. Remember, what is that? Normally, what is that? Treatment level. For the treatment, what you need to have? Lithium should be about 0.8 to 1.2 milliequivalents per liter. Okay. Then, for example, if you are using it as a prophylactic usage, prophylactic means if you are preventing the symptoms of, for example, BPD, then it can vary up to 0.6 to 1.6. 0.6 to 1.6. If it is more than 2, then it is a toxic range. So you need to maintain below here only. Okay. So therapeutic drug monitoring means you are going to measure the drug level. You are going to measure what? Drug level in the body. So the TDM is done for drugs such as, can anybody tell me? TDM can be done for what are the drugs? This question was also asked. TDM is done for drugs such as phenytoin. TDM is done for drugs such as digoxin. Then TDM is also done for lithium. All these conditions. So they can ask you all of the following drugs require therapeutic drug monitoring except, so if we have 3 drugs, you need to remember even for the heparin, unfractionated one. Okay. Now, once we understood about this, let's go to the next important drugs. Shall we go? Able to understand? First, let me see. Are you people able to understand? Follow me. Yes or no? Okay. Now, if there is a lithium toxicity, guys, lithium toxicity is there, the better treatment we would go for a dialysis. Okay, let's go to the next aspect. The next aspect, what is that? The most important aspect which you need to learn about is anxiolytics. And hypnotics. Now, anxiolytics and hypnotics are very easy but very important. So, what exactly you need to understand? Guys, you have one of the neurotransmitter, that is your inhibitory neurotransmitter. What is that inhibitory neurotransmitter? That inhibitory neurotransmitter you have is GABA. What is the full form of GABA? Gamma aminobutyric acid. Now, GABA is derived from which neurotransmitter? GABA is derived from what? That is, GABA is coming from a glutamate. It will undergo a reaction called as decarboxylation, will give rise to GABA. Okay, gamma amino butyric acid. Now, it is a type of inhibitory neurotransmitter. How exactly it works, you need to understand. Consider this is one neuron and here is one more neuron. Okay, now, my dear students, this neuron will release the GABA. Will release what? GABA. Will release what? GABA. Okay, now this GABA will go and act upon the GABA receptor. Will go and act upon the GABA receptor. As soon as GABA receptor is stimulated, it will allow the entry of chloride ions, which will cause the hyperpolarization of the neuron. Which will cause hyperpolarization of the neuron. Okay, now, okay, let me change. Okay, now it will cause the hyperpolarization of the neuron. So, if there is a hyperpolarization, automatically neuron will not get excited, leading to what? Sedation. Leading to what? Sedation. Now, the important thing you need to understand, my dear students, you understood about this so far very well. Okay, now we have some drugs. We have two groups of drugs. One of them is called as benzodiazepines. Benzodiazepines. Okay, now benzodiazepines and one more group of drugs are there, barbiturates. Okay, so there are two groups of drugs, benzodiazepines and barbiturates. What are these two groups of drugs? Benzodiazepine and barbiturates, they act upon what is that? They both act on which receptor? Act on the GABA receptor. But the most important aspect you need to remember is that they act on the GABA receptor, but they have different type of action. What is that? Benzodiazepine, what is that? Increase the frequency of opening. Increase the frequency of opening. What do I mean by this? I'll tell you, people, listen to me. Very easy. Benzodiazepine will go and bind with what is that receptor? GABA receptor. Again, GABA receptor will open, close. So frequently, again and again it will open. Again and again, if it opens, what will happen? Again and again open, again and again chloride ion entry, again and again chloride ion entry, hyperpolarization. Now, barbiturates, what will happen? Increase the duration of opening. Okay, increase the duration of opening. This is an important aspect you need to remember. One of them will increase the duration. So for a long time, who will work? Barbiturates. Again and again, who will work? That is opening, that is benzodiazepines. Okay, now when you look at these two things, yes, both of them will cause an addiction. Both of them will cause an addiction. So it will also cause addiction, but barbiturates addiction will be more higher. So barbiturates will cause more addiction compared to benzodiazepines. Okay. Now, next important aspect, both of these drugs, when you look at these drugs, they will cause hangover. Yes, they will cause hangover. Yes, benzodiazepines will cause hangover a little bit, but barbiturates will cause more of hangover. These are some differences which you need to remember. Now, when you're looking at these drugs, what are the uses of this anxiolytic and hypnotics? So the most important use is your insomnia. What is that? Insomnia. Okay, so insomnia patients can use, what is that? That is your benzodiazepines. Okay, apart from insomnia, there is one more thing, that is your delirium tremens. What is that? Delirium tremens. Now, delirium tremens are what? Delirium tremens are seen with the alcohol withdrawal. Now, if there are alcohol withdrawal, during the alcohol withdrawal, patient can develop delirium tremens. Okay. Now, the next important aspect, see, the most important thing you need to understand, apart from delirium tremens, where else we can use them? They can use them in the treatment of anxiety. What is that? Anxiety and even for the panics, little bit. Anxiety and panics. Okay. Now, the next important aspect, see, delirium tremens covers here. Okay. The most important aspect, they're used for the seizures. Seizures treatment also we are going to use, what is that? That is your anxiolytic and hypnotic drugs. Okay, now let's understand what are the drugs we need to know. Okay, we have benzodiazepines, right? Benzodiazepines, BZD, benzodiazepine, we have drugs such as diazepam. What is that? Diazepam. Okay, we have one more drug that is called as lorazepam. Now again, there are MCQs here. I want you people to understand lorazepam. Apart from lorazepam and diazepam, we have one more drug. What is that? That is your alprazolam. Alprazolam. Okay, apart from alprazolam, we have one more drug that is only you are called as clonazepam. What is that? Clonazepam. Okay, apart from clonazepam, there is one more drug that is only called as midazolam. Midazolam. Okay, so these are the few drugs. So there is a long list, but these are the widely you need to remember these drugs. Okay, now listen to me very carefully. Lorazepam is used drug of choice for status epilepticus. For status epilepticus. Okay, now please understand diazepam is the drug of choice for status epilepticus. If not in option, if not in the options, then you can mark midazolam. Okay, so this is the importance you need to understand. Okay, so please listen to me. If that is not their drug of choice is lorazepam. If that is not there, you can go for midazolam. Clinical practice, especially in the government setups, usually the available drug is midazolam. That is what we are going to use. Okay, now diazepam, alprazolam, other things, they are used for insomnia, but diazepam also works as a myorelaxant. What is that? Myorelaxant. What is that? Myorelaxant drug. It also works as a centrally acting myorelaxant drug. Okay. Now, alprazolam and clonazepam usually used for insomnia. Usually used for insomnia. Okay. Now the thing is that for example, so now listen to me very carefully. When you're learning about what is that benzodiazepines, so diazepam is there, lorazepam is there, alprazolam is there, clonazepam is there, midazolam is there. Among all these drugs, see, we have different drug kept for different uses. Okay, which benzodiazepine is used for the used for the myorelaxation property? Then it is your diazepam. Okay, now most importantly, you need to understand. For example, some patient overdosed. What is it? Overdosed with your benzodiazepine. What will be the treatment? Tell me. So, antidote for benzodiazepine. Let's see. Okay. Tell me, let's see. So, very good. That is your Flumazenil is the antidote for benzodiazepine overdose. For opioid overdose, naloxone. Okay, antidote for benzodiazepine overdose is your flumazenil. Okay, now here only let's see, where do we use this famiprazole? Famiprazole, where do we use? So if you have some difficulty with watching the video, try reloading the video. Okay, it is used for. We'll come to barbiturates. Okay, now tell me, famiprazole is used for antidote for what? Antidote for alcohol. Antidote for alcohol. You might be thinking, yes. For ethanol toxicity, we can use famiprazole. For methanol toxicity, we are going to use ethanol. Okay, remember. Okay, let's go to the next important aspect. What is that? Let's talk about the barbiturates. What is that? Barbiturates. Now, when I'm talking about barbiturates, we have drugs such as phenobarbital. What is that? Phenobarbital. My dear students, phenobarbital or phenobarbital is a very important drug. I'll tell you why. Phenobarbital, then there is one more drug called as thiopental. That is thiopental. This thiopental is used in the anesthesia and it is also used in one more place. Let's look at here. It is used as an induction agent. Again, clinically not widely used. Induction agent in anesthesia, but clinically not widely used. Nowadays, thiopental is majorly used as a truth serum. Truth serum. What is that? Truth serum. Truth serum is a combination of two drugs. What is that? Hyoscine, that is scopolamine, which I told you. Hyoscine plus thiopentol. Okay, so these are the drugs. What is that? For the truth serum. Okay, now phenobarbital is a type of drug which is used for epilepsy and all. Agree with you people, but listen to me very carefully, my dear students. What is that? Phenobarbital is also used. It is a type of inducer, right? It is a type of enzyme inducer. Okay, so I told you about the use of the midazolam. Midazolam, I have written it here only in the patient with a status epilepticus. We are going to use midazolam if what is not there, lorazepam is not there. Okay. Now, inducer. If it is an enzyme inducer, my dear students, you need to remember it is used for one disease called as Crigler-Najjar syndrome. Crigler-Najjar syndrome. In the patients with the Crigler-Najjar syndrome, there is a wide range of treatment that includes your phototherapy, etc., etc. Along with that, we can consider a use of one drug, that is your phenobarbital. Okay, there are other drugs such as secobarbital and all. So that is not so important. Let's continue to the next aspect. So the next important aspect, guys, we are going to learn about the anti-epileptics. What is that? Anti-epileptics. So anti-epileptics are the drugs which are used in the treatment of epilepsy. So when we are talking about epilepsy, let me tell you about the epilepsy very quickly right here. Okay. Now when you're talking about epilepsy, so epilepsy, before going to epilepsy, you need to understand one thing. What is that one thing you need to understand, guys? See, patient will have a seizure. If there is a repeated episodes of the seizure, then we call it as epilepsy. If there is a repeated episodes of the seizure, we call it as a epilepsy. So it is a syndrome, it is a disease in which repeated episodes of the seizures are there. Now, if the patient is getting seizure, there are multiple causes such as stroke, such as idiopathic causes, such as trauma. Okay. For example, vitamin deficiency, such as calcium deficiency, such as fever, all these things, fever in the children leading to febrile seizure. Okay, in all these cases, we call it as a seizure. Now, seizure, if there is a repeatedly, then we call it as, what is that? Epilepsy. Now, a patient with epilepsy, what exactly you need to understand, guys? We need to treat the patient with epilepsy. So, to treat the patient with epilepsy, understand one thing here. What is that? Guys, there is a neuron. Okay. Now, this neuron will produce one neurotransmitter. What is that? One neurotransmitter. What is that one neurotransmitter it is producing? Let's see. Okay. The neurotransmitter it is producing, let's consider it is producing your glutamate. What is it? Glutamate. Now, this glutamate can go and act upon, what is that? That can act upon its receptor, glutamate receptors. What are the glutamate receptors we have? Receptors such as NMDA and AMPA receptor. Which are those receptors? NMDA and AMPA receptor. Okay. Now, NMDA and AMPA receptor, what they will do? They will allow the entry of calcium ion and they will allow the entry of sodium ion. If calcium and sodium ion comes into a neuron, neuron will get excited. If neuron gets excited, what will happen? Let's see. Let's come back to the epilepsy. So, for epilepsy, you need to understand seizure. So, seizure is what? It is an abnormal neuronal discharge. Abnormal neuronal discharge. If there is an abnormal neuronal discharge, what exactly it is going to happen? Guys, there is an abnormal neuronal discharge because of which there is an excessive excitation of the neurons. So, we need to block that. We need to do what? Block that. Okay. So, excessive activation of the neuron, that is leading to seizure. Okay. So, what you can do? What you can do is that understand if there is an increase of stimulatory neurotransmitter such as the glutamate, or if there is a decrease of what is that? That is your inhibitory neurotransmitter. Means, see, stimulatory, inhibitory, both of them balance. What should be there? Balance should be there. Now, what will happen? One of them, inhibitory, consider this inhibitory will go down, stimulatory will become more, automatically it might lead to epilepsy. So, the treatment target, we are going to play with the neurotransmitter. That is the target. Okay. Now, there is a decrease inhibitory. Now, what is that? They can lead to, what is that? They can lead to seizure. Okay. If they can lead to seizure, now what exactly we need to do? So,
we have sodium channels. We can block the sodium channel. If you block the sodium channel, what will happen? Sodium is blocked. If sodium is blocked, no entry of sodium. If there is no entry of sodium, then automatically there is no excitation of the neuron. That is the one way to treat. Then there is one more way. Calcium channels can be blocked. But I want you to understand, guys. Let's go back little even more depth. What is that? So this glutamate, if it has to be released, it was stored here inside a synaptic vesicle, Upon this synaptic vesicle, there is a protein called as SV2A protein. There is a protein called as SV2A protein. Now remember, the neuron will get excited. Okay, now the that is excited electrical activity comes, which will allow the entry of calcium ions. Now after calcium ion entry, it will go and act upon what is that? Synaptic vesicle. Now this synaptic vesicle will use the help of this protein called as SV2A. After that only glutamate will be released. Now that will go and stimulate the receptor. This is the summary of the neurons activity. So let's look at the anti-epileptic drugs. So first important thing, what is that? SV2A blocker or inhibitor. SV2A inhibitor. Tell me, what is that SV2A inhibitor we have? So where is SV2A? All of you know that. So what is that SV2A inhibitor we have? What is the SV2A inhibitor we have? Let's see. Take a guess. So SV2A inhibitor, what we have is, my dear students, that is only your levetiracetam. What is that? Levetiracetam. This levetiracetam is a drug which is what? SV2A inhibitor. What is that? SV2A inhibitor. Now this is very important because, guys, understand, this can be used to prevent the seizure. It can be used to prevent the seizure. Prevent the seizures means a patient comes to you with a head injury. You know that patient can get, what is that? Seizure. So to prevent that from happening, you can give a levetiracetam. What is that? Levetiracetam comes under brand name Levipil. Okay, comes under brand name Levipil. Okay, now, this levetiracetam, also understand one more thing. So please listen to me. Levetiracetam is a drug of choice for what is that? Pregnancy female with the epilepsy. So if a pregnant female is having epilepsy, now you can give which drug? Levetiracetam. If not in the option, then what you are going to give? If that is not in the option, then you are going to use a drug called as lamotrigine. What is it? Lamotrigine. So remember, the best drug is so today's we are going to use levetiracetam. Earlier we used lamotrigine. Now you can consider them as equally effective, but so we are going to consider this as a better drug compared to that of lamotrigine. This is a story you need to remember. Okay, now now we have something. What is that? That is your sodium channel blocker. Sodium channel blocker. Now, sodium channel blockers, we have drugs, my dear students. Drugs such as one of the most important drug, that is your phenytoin. What is that? Phenytoin. What is that? Phenytoin. Apart from phenytoin, then we have one more thing, that is your sodium valproate. Sodium valproate. There is one more drug, that is your lamotrigine. Just now I told you people. What is that? Lamotrigine. Then there is one more drug, that is carbamazepine. What is that? Carbamazepine. Then there is one more drug, that is oxcarbazepine. Now, when you look at all these drugs, my dear students, what you need to understand? You need to understand there are some important MCQs which are related to each drug. Okay. Now, remember this. Phenytoin. What exactly it will do? My dear students, it will inhibit an enzyme called as collagenase. It will inhibit an enzyme called as collagenase. What is that? Collagenase. Okay. So it will inhibit an enzyme called as collagenase. So since it inhibits an enzyme called as collagenase, it will cause one side effect called as gum hyperplasia. Gum hyperplasia. Now,
you people might have read about this phenytoin, which improves, which improves, what is that? Which improves wound healing, promotes the wound healing. Again, that is because of the enzyme. What is that? Collagenase. Which enzyme? Collagenase. If they ever ask you a question for you people, the phenytoin causes gum hypertrophy, gum hyperplasia, because of which effect? Because of inhibition of an enzyme called as collagenase. Because of an enzyme called as collagenase. Now, apart from that, guys, let's look at the next important aspect. What is that? You have phenytoin. Now, this phenytoin will cause one more side effects. Let's look at the side effect. Other side effects. It will cause megaloblastic anemia. It will cause megaloblastic anemia. Megaloblastic anemia. It will also cause vitamin K deficiency. Vitamin K deficiency. Now, apart from that, if used in a pregnant female, it can lead to something called as fetal hydantoin syndrome. Fetal hydantoin syndrome. So this can be the side effects which can be caused as a result of fetal, that is your phenytoin. Okay. Now, if you have a phenytoin overdose, my dear students, what is that? So somebody told ataxia. Now I'll come to that ataxia point. That is, if the patient is having a overdose of phenytoin, then you are going to have ataxia as a side effect, or ataxia as a clinical feature. Now, sodium valproate. Now, sodium valproate also causes some side effect which is very important to be remembered. What exactly is that? That is, my dear students, that is, it will increase the risk of PCOD. It will increase the risk of PCOD, and it will also increase, it will also cause weight gain. 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 Clear? Thank you. Now, let's go to the next aspect. What is that next aspect? The next important aspect, guys, you need to understand what exactly is that. Lamotrigine can be safely used for pregnant female. Agreed? Now, carbamazepine is a type of enzyme inducer. These are the quick review points which you need to know, must and should, from these drugs. Okay. Now, I told you people that. Let's go for calcium channel blockers. Calcium channel blockers. Now, calcium channel blockers, guys, please understand, calcium channel blockers are easy to remember. We have a drug called as ethosuxamide. What is that? Ethosuxamide. Ethosuxamide. Guys, please listen to me. Ethosuxamide. Now, ethosuxamide is a very important drug. If the patient age, if patient with absent seizure, can anybody tell me what is absent seizure? Let's see. Describe absent seizure. Describe an absent seizure. So, absent seizure is seen where exactly? Guys, listen to me very carefully. Absent seizures are seen with children. Absent seizures are seen with what? Children. Absent seizures are seen with children. Okay, absent seizures are seen with children, but please understand, okay, patient stops for a few seconds, then comes back. It occurs in kids, loss of consciousness for a few seconds. So please don't tell this loss of consciousness as completely, because loss of consciousness means patient might fall down. So what happens is that, look here, understand, what happens is that, so for example, a small child of, for example, 4 or 5, 6 years age, he'll be sitting in the classroom. Now, he will not fall down. You are right. There is no awareness about the surrounding. That part you are right about the consciousness. But complete loss of consciousness means he should fall down. That is not going to occur. Okay. So, what happens here? So, a child will be sitting like this. Teacher is telling the class. The child will be like this. He'll be having open eye. He'll be looking at the teacher, but nothing is getting registered. He'll be looking like that only for few seconds. Again, he'll come back to normal. So during those seconds, what happened, you don't know. Okay. Now, how will this come? How will these patients will come? Okay. Now, how these patients will come is very important thing is that, so the poor school performance, mother will bring the child saying that teacher complains about the poor school performance and he's having some, what is that, zone out. He'll be like, in his own world for a few seconds, then he'll come back. Zone out for a few seconds, come back. It might occur up to 35 to 40 times or even up to 50 times a day. That type of seizure, we call it as a absent seizure. Okay. Now, when there is this condition, if the age is, you look at the age, if the age is less than 2 years, 2 years, there is a different treatment. If it is more than 2 years, then what is the treatment? If less than 2 years, you are going to use ethosuxamide. What is that? Ethosuxamide. Okay. Now, if it is more than 2 years, valproate. More than 2 years, valproate. More than 2 years, valproate. So this is a very important MCQ which is asked. Okay. Very nice. So is it just a complete loss of consciousness or loss of attachment with the reality? Loss of attachment with the reality, but the patient psychomotor knows, like, there is no motor symptoms, only and only he'll be having these blackouts. This is a very important question because on the day of exam, the examiner will describe the case and you people will go quiet. So this should not happen. Okay. So let's continue to the next important aspect. What is that? That is your anti-epileptics. But let's talk about the other drugs. What is that? GABAergic drugs. What is that? GABAergic drugs. What is this GABAergic drugs? These drugs will work with the help of GABA system. All of you know one drug which we already discussed, benzodiazepines. Apart from benzodiazepines, we can also use barbiturates. Apart from this, my dear students, I want you people to understand there are other 2 to 3 drugs you need to understand. So consider this is one neuron, consider this is a second neuron. Okay. Now this is which neuron? This is a GABA neuron. Okay. This is a GABA neuron. How this works? Let's understand. Okay. Now, whatever GABA is there, it will be released. Okay. GABA is released. Now, GABA will do its action of what is that? Stimulation of GABA receptor, allow the entry of chloride ions, which we already know. Now, let's go to the next aspect. What happens? This GABA is this GABA is taken up by GABA transporter. Okay. Now GABA comes into the neuron. This GABA can be metabolized into metabolites by an enzyme called as GABA transaminase. So what are the 2 things you need to focus here? Guys, one of them is there, GABA transporter. One more is GABA transaminase. So we have a drug that is your GABA transaminase inhibitor. What is that? GABA transaminase inhibitor. Can anybody tell me the name of the drug? GABA transaminase inhibitor. Let's see. Okay, tell me, GABA transaminase inhibitor. What is the name of the drug? Not valproic acid, my dear. Not valproic acid. GABA transaminase inhibitor. The name of the drug is your, what is that? Vigabatrin. What is that? Vigabatrin. What is the name of the drug? Vigabatrin. Okay. Remember, what is that? GABA transaminase inhibitor. GABA, here we have GABA, TR for transaminase, IN for inhibitor. Vigabatrin, GABA transaminase inhibitor. Please don't get confused. I knew that most of us get confused between tigabayne and vigabatrin. Very good. Whoever said vigabatrin, you are right. Vigabatrin. What is that? Vigabatrin. Now, vigabatrin is what? It is a GABA transaminase inhibitor. The name itself has GABA, TR for transaminase, IN for inhibitor. Okay. Now, how to remember one more aspect? It will cause one side effect. What is that? Side effect. That is visual disturbance. What is that? Visual disturbances. My dear students, visual disturbances. Again, here only look back and understand. VI for visual disturbance. You can remember it. Clear? Now, I'm not talking about some special scenarios here because I want to put those into one place where there is so many MCQs. Okay. Now, GABA transporter is inhibited by a drug called as tigabayne. What is that? Tigabayne. Clear, everybody? So these are the drugs we have. Okay. Now, there are other drugs which acts with the GABA system. GABA system. We have drugs such as pregabalin, and there is one more drug. What is that drug? Pregabalin, and there is one more drug. There is one more drug, that is your gabapentin. What is that? Gabapentin. What is that? Gabapentin. Okay. Now these two drugs are usually used for what? Listen to me. They are neuroprotective. They are neuroprotective. Since they are neuroprotective, they are used for what? Used for neuropathy. Used for neuropathy. Which neuropathy, my dear students? The neuropathy that is your, for example, peripheral neuropathy caused by diabetes mellitus patient. We are going to use this drug. We are going to use this drug, that is your pregabalin and gabapentin. We have other drugs such as vigabatrin and tigabayne. So all the anti-epileptic drugs are done. Now we are going to study about some special scenarios. What are those special scenarios? The special scenario number one. Special scenario number one. What is that special scenario number one? That special scenario number one is your febrile seizure. Febrile seizure. So febrile seizure is caused by fever. Caused by fever. Okay. So caused by fever seen in children. Caused by fever seen in children. Okay. Now please understand, to prevent this from occurring, what you need to do? If seizure already present, what you need to do? If seizure already present, what you need to do? If at all, to prevent, what you need to do? So if you need to prevent the seizure, which seizure? Febrile seizure, to decrease the fever, So basically antipyretic drugs to decrease the fever, so seizures won't develop. Okay, very good. Now, if there is seizure which is already present, then you are going to use, what is that? Per rectal diazepam. Per rectal diazepam. Okay, so please understand, if seizure is already occurring as a result of fever, to treat the seizure you are going to use, what is that? You are going to use per rectal diazepam. Then apart from that, you need to rule out the causes. Of course. What are the rule out the causes? Because if fever is there, fever is causing the seizure, that might be fever itself or meningitis. That is a pediatric approach, I agree. But the thing is that if I ask anybody ask you what is the febrile seizures drug of choice, your answer should be always, you need to go for a per rectal diazepam. Okay, per rectal. In kid you find an IV, it is very difficult in an emergency case scenario. So that is why we prefer per rectal. Okay. Let's go to the next aspect. What is that next aspect? See, if a patient comes to you with a seizure and fever and there is some neck pain and all, you can rule out meningitis. But the most important aspect is that you need to control the seizure immediately, then you do all the diagnostics. Let's go to the next aspect. Then pregnant female. Your most important, pregnancy. Now most important and most confusing for everybody. Okay, understand. Now I'll break this complete confusion of yours in 1 minute. How exactly? Guys, very simple. Okay, what is that? Very simple. That very simple aspect is that, guys, if the pregnant female with epilepsy, that is one scenario. Pregnant female with epilepsy. Then there is one more scenario. The pregnant female who is having a hypertension plus proteinuria plus your seizure. Now, these three things, if they are present, we call it as eclampsia. Okay, if pregnant female is having just epilepsy, for example, imagine before pregnancy also she was having seizure. Now she became pregnant. Now what is the drug to be given? See, pregnant female before pregnancy she used to get the seizure. Now she became pregnant. After pregnancy we need to change the drug. Okay, so what exactly is that? Pregnant female with the epilepsy, the best ones are levetiracetam. If levetiracetam is not there, lamotrigine. Okay, now the next important, if that is also not there, then carbamazine. These are the three drugs. Next, eclampsia is there. Then what you are going to give? IV MgSO4. What is that? IV MgSO4, magnesium sulfate. Okay, this is how you are going to treat the patient. Okay, levetiracetam, lamotrigine, carbamazepine. See, guys, actually speaking, now levetiracetam and lamotrigine said to be having similar effect in the pregnant female, but you can go for, if all of them are given, the best answer would be levetiracetam, then go for lamotrigine. Got the clarity? Okay. Now, after you understood about the pregnancy, then there is one more important aspect. What is that? If the patient is having a generalized tonic-clonic seizure, GTCS. If the patient is having a GTCS, best drug is valproate. Best drug is valproate. After that, valproate, if that is not there, then you can go for lamotrigine. Okay, so these are the all important aspects which are related to your, what is that, which are related to your most important aspect of your central nervous system's epilepsy. So we are left out with one topic, that is your antidepressants. Again, many questions were asked, so let me teach you people. Now before going there, let me tell you people, dopamine. Dopamine in central nervous system, sorry, dopamine in the central nervous system. Okay, sorry guys. Now, when you want to understand dopamine in the central nervous system, let's understand it. So please focus your attention here. Dopamine will go and trigger D2 receptors in chemotrigger zone. Will go and trigger D2 receptors in the chemotrigger zone, which will cause vomiting. Okay, so anytime if you are getting vomiting, one of the reason, I'm not telling always. Okay, for example, you are going in a, for example, all the weird rides. Okay, that is taking you reverse and all. That time, that is not because of dopamine, that is not because of chemotrigger zone, that is because of vestibulocochlear apparatus. Okay, so that is the thing. So one cause for vomiting, chemotrigger zone, is your dopamine. Okay, the next important aspect, dopamine will, if dopamine, what exactly it works, it will, if at all dopamine receptor, D2 receptors are stimulated, if D2 receptor are stimulated, then it will decrease the prolactin production. It will decrease the prolactin production. That is why we used which drug? That is cabergoline, bromocriptine in prolactinoma. Why? Because look here, it will decrease. If you stimulate dopamine receptor, automatically it will decrease the prolactin. It will decrease the prolactin production. Then next important aspect, dopamine receptor, if you get D2 receptors, if they are excessively stimulated, they can also lead to psychosis. That is why we used antipsychotic drugs. Okay, then the next important aspect, so for that so if there is D2 stimulation, that will cause psychosis. The treatment is antipsychotics. If you give a antipsychotics, my dear students, they will cause extrapyramidal symptoms. So I wanted to teach you people with dopamine. That is why I didn't mention about extrapyramidal symptoms in the antipsychotics. Okay, now let's talk about growth hormone. We will come to growth hormone also. Okay, the growth hormone I will talk in endocrinology. Okay, extrapyramidal side effect. What are those side effects? Can anybody tell me what are the side effects? Extrapyramidal side effect. Let's see. What are the extrapyramidal side effects you have, my dear students? Tell me. What? Atypical ataxia. Anything else? Loss of posture. Okay. So tone. Write down the side effects such as guys, it can lead to ataxia. Apart from ataxia, it can lead to akathisia. Okay, the patient can develop tremors. Along with that, perioral tremors and perioral tremors. Okay, now perioral tremors are usually earliest sign of the extrapyramidal symptoms. Okay, now if dopamine receptors are blocked, if D2 receptors are blocked in a place called as thermostat, the area which is responsible for You are responsible for your temperature control. It will lead to a disorder called as malignant. What is that? Malignant. Which malignant? So I knew that all of you will tell what is that? Malignant hyperthermia. No, it is called as malignant. That is why I put it right down. That is called as neuroleptic malignant syndrome. Okay, neuroleptic malignant syndrome. It will lead to neuroleptic malignant syndrome, not malignant hyperthermia. Malignant hyperthermia is having a little bit different story there. Okay, neuroleptic malignant syndrome. Which malignant? Neuroleptic malignant syndrome. Okay, so please understand this particular aspect. Okay, so this is a story of your dopamine. Let's go to the next aspect, that is your antidepressants. Antidepressants are going to be very quick because it is very easy. Antidepressants. Now, when you are learning about antidepressants, so there is a theory for antidepressants also. Now, the theory about depression, what exactly it says that, so listen to me very carefully. I have one neuron here, there is one more neuron here. Let's take one neuron right here and one here. Okay, now exactly what I'm trying to tell you people is that this neuron, consider it was releasing serotonin, that is only 5-HT. Okay, this neuron, consider it is releasing norepinephrine. Okay, so basically they used to tell us that, what is that? The people used to, the theory used to tell us that if there is a decrease of norepinephrine and 5-HT, that is serotonin in where? Exactly in the synapses. In the synapses will leads to depression. That was the theory. Okay, what was the theory? It will decrease norepinephrine, serotonin in the synapses. That is why that is causing the depression. Okay, clear? Now, what exactly we started to do? For example, this 5-HT, whatever is released, it usually used to reuptake. What used to happen? Reuptake used to happen. Okay, 5-HT will work on the neuron, agreed. Now, norepinephrine also whatever released, reuptake. Norepinephrine also whatever released, reuptake. What is that? Reuptake. Okay. Now, listen to me very carefully. Norepinephrine, whatever is there, it is also getting reuptaken. Serotonin also reuptaken. So, basically, what exactly we need to do? We need to do is that, for example, SSRI. What is that? SSRI. Basically, they are selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors. Guys, selective serotonin reuptake inhibitors are very, very important. Why? Because SSRIs are a very important MCQs. So, what are the drugs we have? Drugs such as fluoxetine. Okay, we have drugs such as citralopam. Okay, we have drugs such as, what is that? That is your, most importantly, what is that? That is paroxetine. Okay, now all these drugs, there are other drugs also. So citralopam, acetalopam, okay, all of these come under selective serotonin reuptake inhibitor, but they're least interested about knowing the names. They will ask you the uses of the SSRIs. Uses of the SSRIs very important for exam. So if you are learning about, if you remember one drug also totally fine. Even if you remember one drug such as fluoxetine or paroxetine, no problem. But the major issue is that they will ask you the uses. What are the uses? Of course, all of you know they're used for the depression. They're used for the depression. If the life was that simple, no problem, because pharma wouldn't be that difficult. Because yeah, antidepressant, depression, antiemetics, vomiting, okay, antibiotics for bacterial infection, that is very easy. No, that is not like that. So listen to me very carefully. There are other uses. Guys, listen very carefully. These are used for psychogenic, premature ejaculation. So, what is the most common cause of PE? Premature ejaculation. Most common cause is psychogenic. The cause of psychogenic premature ejaculation is psychogenic. That is the most common cause. So, the treatment will be selective serotonin reuptake inhibitors. Apart from that, they are also used for PTSD. They are also used for obsessive compulsive disorder. They are also used for anxiety. Okay. Now, what are the few important things. So if at all, if you are remembering, I would like you to remember these most 100% have to remember points. So PTSD, OCD and psychogenic premature ejaculation, because all these questions are very important and which are asked, okay? Especially these three important points are asked in last 1 year, okay? Clear? Okay. Now, the next important aspect. So, anxiety in anxiety itself you put to GAD, generalized anxiety disorder. Okay. Then next important, we have something called as SNRIs. We have something called as SNRIs which are used for the depression, such as vanlaflaxine. Vanlaflaxine. Okay. So, this is there. Now, the most and most important are your tricyclic antidepressants, guys, TCAs. So, these TCAs, they will also inhibit what is that? Serotonin. And there is one more thing. What is that? Norepinephrine. So you might be asking, sir, serotonin, norepinephrine, SNRIs also there, na? SNRIs also there, na? Okay, you also write if you want duloxetine. Okay, now listen to me, sir. Serotonin, norepinephrine reuptake inhibitor is there. Then what is the difference about TCA? TCA also inhibiting serotonin, norepinephrine reuptake? Norepinephrine reuptake. Then the question is, understand these TCAs are named after their structure. It will have three cyclic structures in its this thing. What is that? In its chemical structure. So that is why we call it as a tricyclic antidepressants, my dear students. What is that? Tricyclic antidepressants. Okay. So listen to me very carefully. Tricyclic antidepressants. We have drugs such as amitriptyline. Okay. Apart from that, we have one more drug, that is nortriptyline. Okay. Then we have drugs such as imipramine. Okay. So there are big list of drugs. At least you need to remember these few of them. What is that? That is your amitriptyline, nortriptyline and imipramine and clomipramine. Okay. Among these three are very important, because all of these drugs are very much important as a result of as for the MCQ and other uses apart from the depression. So what are the uses of the TCAs, my dear students? These uses are very important MCQs. One of them is a nocturnal anuresis. For the patient with the nocturnal anuresis, especially in the children who is not able to hold their urine, especially after a certain age. So through a certain age, they should be able to retain their urine during the night time, or they should be able to wake up and go to urination. But if they're losing the control and bedwetting is there, for that we can use it, nocturnal anuresis. Then apart from that, the most important, migraine prophylaxis. So far I have told you people two drugs. What are those two drugs? That is your what are those? That is your nocturnal anuresis and migraine prophylaxis. What is that? Nocturnal anuresis, migraine prophylaxis. For migraine prophylaxis, two drugs, tricyclic antidepressant and propranolol. Okay. Then apart from that, sir, where else we are going to use this? So apart from that, tricyclic antidepressants, especially imipramine used for hyperactive bladder. Okay, so imipramine is used for hyperactive bladder. Then apart from that, they can be used for anxiety. But not as a so much important ones. Okay, so these are some important uses which you need to remember apart from the depression. Okay, so this is the story of your central nervous system. So when we studied about central nervous system, there are some important aspects which I want you people to go through from my side. Now quickly listen to me, whatever I'm going to say. These are going to be very important points. If you want, note down the timing in the video. Later also you can watch and make the points, but I want you to listen to me and repeat with me. Okay, so what is the most potent opioid? Fentanyl. What is the most potent opioid? Fentanyl. Prototype opioid? Morphine. Antidote for opioid overdose? Naloxone and naltrexone. Antidote for your benzodiazepine overdose? Flumazenil. Antidote for this one is, what is that? Flumazenil. Okay, benzodiazepine will increase the frequency of opening, barbiturates will increase the duration of opening. Okay, now these are some important points. SV2A inhibitor, levetiracetam. Calcium channel blocker acting as an anti-epileptic drugs, that is calcium channel blocker in the CNS, that is your
ethosuxamide. Then what is the side effect caused by phenytoin? Fetal hydantoin syndrome, megaloblastic anemia, and which enzyme is inhibited by phenytoin collagenase? Which enzyme is inhibited by phenytoin collagenase? Okay, what what anti-epileptic drug? Which anti-epileptic drug is used for the treatment of status epilepticus? That is yes, that is lorazepam. Okay, anti-epileptic drugs for the treatment of status epilepticus, lorazepam. If not there, midazolam. Not there, midazolam. Pregnancy female, lamotrigine. If there is eclampsia, magnesium sulfate. So all these are very important, frequently asked questions. So what is the drug of choice for your, what is that? That is your psychogenic premature ejaculation, that is SSRIs. Which antidepressants are used for, that is your treatment of nocturnal anuresis, tricyclic antidepressant, and prophylaxis of migraine also tricyclic antidepressant. With this much being said, I want to give you some points here. Write down those points. What is that? So these are not related to antidepressants, but related to overall CNS. There is first important, there is an opioid, tramadol. Tramadol is a opioid, but opioid with inhibitor of serotonin and norepinephrine reuptake property. This is a very important MCQ which can be asked for you people in this coming exam. Okay, then next important aspect, treatment of barbiturates overdose. What is the treatment of barbiturate overdose? Now please tell me, anybody. So barbiturate overdose is there. Okay, there is no antidote, we'll let him die. We'll do. Patient, sir, barbiturate overdose came, there is no antidote, so let's leave the patient and let him die. We can't do that. So what is the treatment? So what is the treatment is that, guys, you are going to do forced alkaline diuresis. So forced alkaline diuresis is the treatment of your barbiturate overdose. Listen to me. Barbiturates are a type of acidic drugs. What is that? Acidic drugs. Listen to me very carefully here. Acidic drugs. Now listen to me very carefully. Acidic drugs. Okay. This is your nephron. Okay. Normally pH of the urine is acidic. Now what happens is that I have a patient with overdose of which drug? Barbiturate. Now barbiturate will come into where? Into the nephron. Okay, once it comes into the nephron, barbiturate drug will get filtered. Okay, drug got filtered. But the most important point is that it is a type of acidic drug and urine pH is acidic. Now drug can get reabsorbed very easily. So if it is getting reabsorbed, again it is going back to the blood. So please pay attention. Acidic drug in acidic media gets absorbed. Applying that logic, barbiturate is an acidic drug which can get absorbed in from the urine. Now what I have to do? I have to change this pH from acidic to alkaline pH. So if alkaline pH is there, so now the pH has changed into alkaline pH. If alkaline pH is there, now will the drug get reabsorbed? No, drug cannot get reabsorbed because the drug is an acidic drug in which media? Alkaline media. In which media? Alkaline media. So why exactly you are making the urine alkaline? Because to prevent tubular reabsorption. To prevent the tubular reabsorption of the drug. Okay, this is a very important MCQ which can be asked, which was not asked yet. So that means this is a MCQ, new one possible, and be very much ready with it. That is to prevent the tubular reabsorption, we are making the urine into alkaline. Now diuresis means increase the urine output. We are trying to remove the drug. Okay, so what exactly you need to understand? To prevent the tubular reabsorption, what you are doing? You are making the pH from acidic into alkaline. Which pH? Urine pH. Okay, that is called as fetal hydantoin syndrome, which is already explained. That is fetal hydantoin syndrome. Okay, now this is the aspect about barbiturate overdose. Now apart from this, guys, listen to me very carefully. There are some drugs, MAO inhibitors.
Now, if MAO inhibitors, monoamino oxidase, so MAO is an enzyme responsible for the metabolism of serotonin. Okay. Now, MAO inhibitors, if used with SSRIs, what will happen? So MAO is responsible for the metabolism of serotonin. MAO inhibitors, if they are used with the SSRIs, so MAO inhibitor, if they are used with the SSRIs, what is going to happen? Let's see. It will lead to a syndrome called as serotonin syndrome. What is that? Serotonin syndrome. This serotonin syndrome is also a very important MCQ, that is caused by which substances? MAO inhibitor, monoamino oxidase inhibitors along with SSRI. See, you give a SSRI, more serotonin in the neuron. Now, you inhibit a MAO, even more serotonin. Because of elevated level of serotonin, the syndrome we are going to get is a serotonin syndrome. Clear? So, how to make urine alkaline? My dear student, to make the urine alkaline with the help of one substance, sodium bicarbonate. Don't do anything with your acetazolamide, please, but rather use this particular one, NaHCO3, better option for you. All right. So once you understood about the serotonin syndrome, okay. Now, let's go to the next important point. What is that next important point from the central nervous system? That is next important point here is that, guys, please pay attention. That is, for example, we learnt about epilepsy and all those aspects, right? That is valproate and ethosuxamide is a very important point. Now, apart from that, now I want you people to pay one most important attention. Benzodiazepines, if used in insomnia, then what will happen? They will cause the treatment of sleep disturbance. Okay. If barbiturate is already reabsorbed, don't worry now. What is the problem? If barbiturate reabsorbed, no problem. It will come into the blood. Again, it will flowing into the kidney. So again, same story. No problem. Now, benzodiazepine, if used in insomnia, can change sleep cycle. Listen to me very carefully. Sleep cycle can be changed as a result of your insomnia caused by your, what is that? That is your benzodiazepine. Sleep cycle can change. Okay. So if sleep cycle can change, what exactly? The drugs used to treat insomnia without, what is that? Without sleep cycle disturbance, they are your very important aspect. Very important aspect. Without sleep cycle disturbance, they are your most important Z drugs. That is your Z drugs such as zolpidem, zolpiclone. Okay, so all these drugs are your Z drugs, zolpidem, zolpiclone. These drugs are used for what? For the insomnia treatment itself, but which will not change the sleep-wake cycle. Okay. Now, then next important, what is that? Next important aspect, that is about your insomnia. Clear, everybody? Now, if you understood this so far, so whatever points I told you in the end also, they're very important. I can tell you this much that there will be at least CNS questions will be covered. For example, if there is 4 CNS questions, at least 3 questions usually will repeat from these highlights. I can guarantee, because these are the very high yield points. Okay, not that I have some extra imaginary power or something like that. No, this is based on the analysis of how the questions are asked. So based on that, you need to learn how exactly questions are asked so that you can grasp the point. That is the key to study. Okay, so you need to learn, okay, these are the questions which are asked, means they can repeat this question possible. They can ask about next topic which is right here. That is how we need to learn. Got it, everybody? Got it? So yes, of course, there also it will help, because repeated question, same story in profs also. What you are going to do? You are going to repeat the same topic, same mechanism, same rationale.
right? Okay, so with this much being said, let's take a break of 10 minutes and we will come back. Okay, then we will start the next system. Hello guys, welcome back. So we were discussing about CNS, done, right? We were discussing about CNS, done. We were discussing about ANS, done. We were discussing about all the other important general pharma aspects, everything is done. Now, guys, I want you people to pay attention towards one important aspect, that is your heart. That heart related topic, that is your cardiovascular system, is a major chunk of pharmacology. And trust me, this will give you lot and lots of marks, not just from the pharma itself, but also from the other subjects such as internal medicine. Okay. Now, if you know cardiovascular pharma very well, if you know endocrine pharma very well, ANS pharma very well, you can survive all the basic situations which you come across as a doctor. So please understand the importance of pharmacology. You might be thinking pharma, okay, we studied in the in our preclinical subject, that is over. Don't think like that. Pharma is one subject which will haunt you wherever it wants. Okay, what do I mean by this? Any subject can correlate with pharmacology. That much important subject, right? So in that, very important structure is heart. So let's learn about the cardiovascular system. Okay, everybody back? Give me a yes or no. Let's see, everybody, can you hear me? So all of you took a zolpidem and slept off, huh? Yeah, just now you took a zolpidem, you slept off, right? No? Okay, now, guys, please listen to me. So don't take zolpidem, don't take zolpidem, okay? Don't take lithium, don't take any CNS suppressing drugs right now. Now listen to me very carefully, guys. So when you want to learn about cardiovascular system, so before going to cardiovascular system, during autonomic nervous system, let me ask you one simple question, okay? Now, when you run and come home, why parents told not to drink water immediately? Sir, why are you bringing ANS? So ANS can come anywhere. So please pay attention. So why not to drink water immediately? Why did our parents tell that? Because we didn't have water, sir. That is why parents told not to drink water. Any other reason? No, that is not the reason. First thing. Because when you run, oh, glycogen will come and tell water, don't go into the esophagus. Wow, glycogen is such a bone or some tissue, it will come and stop or what? No, not about glycogen. See, I agree with the hormonal changes and all. No, we are not talking about hormonal changes. Now, listen to me very carefully. That is not about glycogen or anything, glucagon, glycogen, nothing related here. So, what exactly is this? Now, when you run, your sympathetic is active. If sympathetic is active, bronchodilation, and along with that, esophageal sphincter will contract. Esophageal sphincter will contract, means upper esophageal sphincter is closed. So all of you need to understand, when you look at a neck, right? In the neck, the anterior most structure is trachea. Behind the trachea, you have your esophagus like this, right? So now what happened is that trachea is dilated, esophagus is closed. Trachea is dilated and esophagus is closed. Now, when you drink water, water is supposed to go into the esophagus. Since esophagus is closed, now water will directly enter into the trachea, leading to aspiration. Now, you are good, you are correct, because of one reason, that is, there is a risk of aspiration. Okay. Now, the same thing. When you lie down and eat the food, I'll sleep and eat the chicken biryani. If you sleep and eat the chicken biryani, what will happen? Chicken will go, instead of into esophagus, it will go into trachea, leading to aspiration. Got it? Okay. Enough of chicken biryani. Let's come back here. What exactly we are going to learn, guys? Let's understand about cardiovascular system. In the cardiovascular system, let's start with one of the easiest topic. What is that? Anti-anginal drugs.
Now, anti-anginal drugs. Now, anti-anginal drugs, I want you people to tell me the definition of angina. What is angina? Till you people tell the definition of angina, let's see, because I want you people to understand the definition. Tell me the definition of angina. Before that, I will not start the drugs. Just take a guess. What is angina? Sir, if this is there, we can call it as angina, like that. Angina means chest pain. Angina means chest pain. That's what we learned. So first important aspect, that is an incomplete definition, my dear. That is an incomplete definition. Why it is an incomplete definition? Chest pain is an incomplete definition. Chest pain is an incomplete definition. You people are right, but partially. What exactly happens is that there is an increase of O2 demand, and there is a decrease of O2 supply, leading to pain syndrome. Leading to what? Pain syndrome. We call it as angina. So what is the important key point here? That is decrease of O2 supply and increase of O2 demand is the key point. Okay, very good. Okay, so wherever it is asked, always answer what is that? Increase of O2 demand and decrease of supply leading to pain syndrome called as a angina. Now angina is divided into, so what is the treatment target? What is the target of treatment? Either decrease the O2 demand. How can you decrease the O2 demand? You can decrease the O2 demand. By what? By decreasing the oxygen demand. This is one way to treat the patient. Then there is one more thing. What is that? Increase the O2 supply. So this is also way to do what? To do the supply of the oxygen. So here what you need to do? Coronary artery dilation. So this is a story of your, what is that? This is a story of your angina treatment. Okay, now when you want to treat the angina patient, let's start with one of the most easiest aspect. That first important aspect, the first and most important drugs are your organonitrates. What is that? Organonitrates. When you are talking about organonitrates, my dear students, organonitrates, what exactly they are going to do, how they are used, what is their importance, let's understand. Okay, now I'll tell you people, this angina topic, especially about organonitrates, it is going to be little bit more advanced compared to any revision course which you can find. So that is our motto. What is that? We are doing a revision and giving you the extreme content here. So let's listen to me, understand. Okay, organonitrates. So when you give a nitrates will go into the body. Under the influence of mitochondrial. There is an enzyme called as mitochondrial aldehyde dehydrogenase. Under the influence of one enzyme, what is that? That is your mitochondrial aldehyde dehydrogenase. It will get converted into somebody called as NO, my dear students. What is that? NO. NO is what? It is basically a smooth muscle relaxant. Okay, so all of you know that nitroglycerin is used sublingually. It is rapidly onset. All these things you people know. So I'm not going to bother with that. I'm going to tell you people that particular information which is having a clinical significance and understanding to be required. Okay, now NO is there. Okay, sir. Now NO will go and act upon what? Will go and act upon a smooth muscle. Consider this is one smooth muscle. What is that? Smooth muscle. Now on this smooth muscle, NO will act. As soon as NO acts, it will stimulate an enzyme called as guanyl cyclase. What is that? Guanyl cyclase. Now this guanyl cyclase converts GTP into somebody called as CGMP. What is that? CGMP. Now understand, so the primary first message was what? NO. After NO, inside the cell, what is formed? CGMP. CGMP will become which type of thing? That is a secondary messenger. It is a secondary messenger. So this particular question was asked previously, what is the secondary messenger of NO? The secondary messenger of NO is CGMP. Very important MCQ. What is the secondary messenger of NO? CGMP. What is the secondary messenger of NO? CGMP. Please don't get confused with CAMP. Okay. Now this CGMP fellow, whatever is there, right? Now this fellow will go and stimulate one substance called as protein kinase G. Protein kinase G. Now this protein kinase G will go and inhibit again same thing, that is only your MLCK, myosin light chain kinase. I told you people, myosin light chain kinase is responsible for contraction of the smooth muscle. Now my protein kinase G did what? It inhibited MLCK. If it is inhibiting MLCK, it will cause a smooth muscle relaxation. It will cause a smooth muscle relaxation. The next important MCQ of the organonitrates is that nitrates, the major action, nitrates action is seen where? My dear students, please listen to me. Nitrate action, the first site of action is veins. The first site of action is veins. The first site of action is veins. Okay, this is a very important. First site of action is veins, followed by that then arteries. So the first and most important aspect, it is veins. Okay, now if you give the nitroglycerin, if it acts on the veins, it will cause venodilation. Venodilation. If there is a venodilation, now listen to me very carefully. Venodilation, vasodilation of the veins. Now what will happen? If veins are dilated, blood will it come back to the heart? Now listen to me very carefully. I'm standing like this. Okay, if I'm standing like this, the blood which are gone into the tissue, that is coming back by veins. If I dilate the veins, automatically blood will pool up in the veins. Blood will pool up in the veins. So venodilation, pooling of the blood in the vein, pooling of the blood in the vein, pooling of the blood in the veins. If there is a pooling of the blood in the veins, it will lead to decrease of venous return. Decrease of venous return. Okay. If venous return is decreased, what will happen? Now tell me, will it affect afterload or preload? If venous dilation is there, it will affect afterload or preload. Venous return decreases, that means it will decrease the preload. It will decrease the preload. If it will decrease the preload, automatically the work of the heart. So heart has to pump the blood, right? If heart has to pump the blood, now what will happen is that if less quantity of blood is coming back, heart has to do more work or less work. Heart will do less work. So it will decrease the preload, which will lead to decrease of the O2 demand. O2 demand. This is the first way of nitroglycerin action. Nitroglycerin action. Very good. Okay. Now, it will dilate the arteries. My dear students, anywhere arteries will dilate. If arteries will dilate, arterial dilation. If arterial dilation is there, that will decrease the afterload. It will decrease the afterload also. Now, the most important MCQ is that, what is that? The MCQ is that nitrates, will they decrease the preload? Yes, sir. Will they decrease the afterload? Yes, sir. So both preload and afterload will be decreased, which will lead to decrease of the O2 demand. That is how our nitrates are working in the relieving of the angina. So this is a very important aspect to be remembered. Okay. Now, nowhere you'll find it in the revision sessions, that too for your crisp manner. So use this information very, very well. Okay. Agreed? Now, once you understood about organonitrates, so organonitrates, once you know about this, now let's go to the next aspect of the organonitrates. These organonitrates, guys, let's understand the uses. Okay, now uses of the organonitrates. So I told you people, they're relaxing all the smooth muscle. They're relaxing all the smooth muscle. If they're relaxing all the smooth muscle, the use is angina. All of you know that. You know that. Okay. Now angina will be divided into stable angina, unstable angina, Prinzmetal angina. We'll come to that. Okay. Now they're used in angina. They're used in conditions such as achalasia cardia. Achalasia cardia. Achalasia cardia is a surgical condition where there is a lower esophageal sphincter spasm. In there only you'll find in barium swallow bird-beak appearance. Achalasia cardia. Apart from achalasia cardia, organonitrates are also used in cyanide poisoning. Cyanide poisoning. So these are some important uses of your organonitrates. My dear students, one of the most important aspect, side effects of organonitrates. Again, this is also a very important aspect. Guys, these drugs will produce tolerance. Tolerance very easily. Tolerance very easily. Okay. Apart from tolerance, they will cause one more side effect, that is your headache. Now, all of you used to tell me what is that? Nausea, vomiting, headache are the side effect of all the drugs, but for nitrates, this is very important specific side effect, that is headache is a side effect of nitrates. Okay. Now, now the next important aspect is that, write down here only, nitrates can lead to dependence, can lead to dependence. Now you people might start to ask me, sir, dependence is caused only by alcohol, opioids, such kind of things. Now how does organonitrates cause? My dear students, organonitrates, if you are using organonitrates for 1 year, now all of a sudden if you stop the organonitrate usage, your patient will get more frequent angina attacks. That is only your organonitrate dependence. It might not be found in the older textbook, but latest textbook says this organonitrates is very evident. The dependence caused by organonitrates is very evident, and this is a very, very important MCQ which can be asked. So all of the following causes, what is that? That is dependence, except in that nitrates, if they have given, yes, nitrates will cause the dependence. So search for the different answer. Okay. Now, once you understood about this much, so organonitrates, we have drugs such as glyceryl trinitrate, glyceryl trinitrate. So we have drugs such as nitroglycerin. Okay. Then we have drugs such as erythritol, tetranitrate. So like this, there are many drugs are there. This is especially long acting. This is a type of long acting drug. Okay. Now I want you people to understand nitrates, organonitrates. What are the routes? What are the dosage forms? What are the forms of the drugs which are available? One of them is their sublingual tablets are available. Apart from sublingual tablets, there is also transdermal patches. So transdermal patches, I want you to remember at least 3 to 4 transdermal patches. One of them is fentanyl transdermal patch, rotigotine transdermal patch, nitrates transdermal patch, nicotine transdermal patch. Nicotine, rotigotine, fentanyl, nitrates. These 4 at least you need to remember in the patch form drugs. Okay, next important. Everybody understood about the organonitrates, route of administration, other mechanism of action and everything? Okay, now scopolamine. Yeah, I told you people about scopolamine also. Very good. Okay, let's go to the next important drugs. So the next important drugs, my dear students, beta blockers. What is that? Beta blockers. Now beta blockers, I want you to understand all the beta blockers which will decrease the O2 demand, already we know about the drugs, which will decrease the O2 demand. Then we also have calcium channel blockers. Now when you're looking at a calcium channel blockers, my dear students, please understand calcium channel blockers which are used in the heart are diltiazem and verapamil. These are the 2 drugs which are specific to the heart only. These calcium channel blockers, got it? Now these beta blocker and calcium channel blockers, these 2 do not combine together. This is an important point. To be remembered. Okay. Now once you understood about this, now let's go to the next important aspect. What is that? They're called as fatty oxidation inhibitor. What is that? Fatty oxidation inhibitors. So fatty oxidation inhibitors. So tell me guys, what are the fatty oxidation inhibitors we have? Are any importance? Why we need to inhibit fatty oxidation in the heart? So remember, so fats will give ketones. Now these ketones are the main energy source. Of what? Of the heart. Don't confuse it with the complete body. For the heart, ketones will be the energy source which are derived from the fats. Okay. Now remember, if fat has to undergo oxidation, fat require Fat require more O2. Fat require more oxygen for oxidation, So for the oxidation of the fat, you require more and more of fatty oxidation. Fatty oxidation require more and more of oxygen. So require more O2 for the oxidation. Now, if fatty oxidation, if they inhibit fatty oxidation inhibition, then what heart will do? Heart will shift to what? Shift the energy source to what? To the carbohydrates. If they shift to the carbohydrates, now carbs require more oxygen or less oxygen? They require less oxygen. For oxidation. That means automatically, what exactly you need to understand? That is O2 requirement will be less. O2 requirement will be less for the heart. Everybody understood? Very good, very good. You are right. Fat require more oxygen for the energy. Okay. So what are the drugs? We have a drug called as trimetazidine. And there is one more drug called as ranolazine. These are the two drugs which you need to remember for the treatment of angina, fatty oxidation inhibitor. So this might be a direct question. How exactly direct question? Which of the drugs work as a fatty oxidation inhibitors? Fatty oxidation inhibitors is a very important question. Okay. Yes, of course, you are correct. I have mentioned ranolazine. Okay. Now, apart from that, there is one more thing. What is that? They are called as rho kinase inhibitor. Now rho kinase inhibitor, understand guys, there is an enzyme called as rho kinase, which will cause vasoconstriction. If I inhibit rho kinase, it will cause vasodilation, which will increase the O2 supply. That's it. O2 supply. What is that? Rho kinase inhibitor. Rho kinase inhibitor, my dear students, that is your sacubitril. What is that? Sacubitril. Okay. So you need to know the name. Which of the following drug is mechanism is rho kinase inhibitor? Can be a direct MCQ. You need to understand that is your sacubitril. Sorry, not sacubitril. I'm sorry. The name of the drug is fascodil. Fascodil. I'm sorry. The name of the drug is fascodil. What is that? Fascodil. Okay. So fascodil, you can remember it like fascodil. Okay. It's working on the heart. Fascodil. Okay. So this is the story of your rho kinase inhibitor and anti-anginal drugs. Once you understood about the anti-anginal drugs, then we are going to next important aspect. What is that next important aspect? Let's learn about antihypertensives. Now, when you're learning about antihypertensives, guys, antihypertensives are a very important group of drugs. So, antihypertensives, again, remember, there will be 1 or 2 MCQs for sure. Okay. Now, let's learn about first-line antihypertensive drugs. First-line antihypertensive drugs. So, what are the first-line antihypertensives we have? Let's see what are those and what are the uses of those, and let's understand. Okay. Now, when you want to understand about first-line antihypertensives, my dear students, first-line antihypertensive drugs, the first and foremost group of drugs, thiazide diuretics. Okay. Now, the next important group of drugs, we have ACE inhibitors. Okay. Apart from that, we have angiotensin receptor blockers. Then we have calcium channel blockers. Then we have beta blockers. So if you know at least these 5 groups of drugs, everything will be easy. So to understand these 5 groups of drugs, let's go and understand one basic way how your body responds to decrease of BP and how we can incorporate our drugs into that particular mechanism. Okay, everybody able to follow? Guys, this is a fascodil, not sacubitril, sorry. Everybody able to follow? Give me an yes or no so that I can continue. Okay. So, let's start. What exactly is that particular aspect? That first and most important aspect, guys, understand hypertension. HTN means hypertension. There is something called as hypertension emergency. Then there is one more thing called as hypertensive urgency. Hypertensive urgency. So, hypertensive urgency and hypertensive emergency. Guys, look here. In both of them, there is an increase of the BP. In both of them, there is an increase of the BP. Okay, the patient is having hypertensive urgency, be it emergency. In that both cases, what will happen? That will be your elevated BP. Along with elevated BP, what will be there? My dear students, one more important aspect. In hypertensive emergency, there is a end organ damage. End organ damage. So, end organ damage. What do I mean by end organ damage? Any condition such as stroke. The patient is having elevated BP with a hemorrhagic stroke, for example. Hemorrhagic stroke. Okay. For example, patient is having a aortic dissection. Aortic dissection. Okay. Along with elevated blood pressure, aortic dissection is there. For example, patient is having a retinal hemorrhage. Retinal hemorrhage. Retinal hemorrhage. Okay. Hemorrhage. Now, all these kind of end organ damages along with the elevated BP, you are going to call it as a hypertensive emergency. So, what do I mean by hypertensive emergency? A patient with a elevated blood pressure came to the hospital with a sudden loss of vision. Sudden loss of vision. You need to think of retinal hemorrhage. Okay, for example, patient came with a severe chest pain and is having a asymmetrical BP and elevated blood pressure. You need to think of aortic dissection. For example, patient came with the symptoms of the stroke and there is a hemorrhagic stroke symptom along with elevated BP, then hypertensive emergency, which is a hemorrhagic stroke. Got it? Now, what is hypertensive urgency? In hypertensive urgency, no end organ damage. Okay. Now, we will come back to its treatment in some time. Before coming back to the treatment, so guys, right now, whatever I'm going to explain, I request you people not to write anything, just pay your attention to me. Just what I'm going to teach, pay your attention. Done? Okay. If there is a decrease of the BP, if there is a decrease of the BP, what will happen? Okay. Now, if there is a decrease of the BP, automatically what will happen is that there is a decrease of the cardiac output. There is a decrease of the cardiac output. And along with that, there is a stimulation of sympathetic nervous system. So, decreased cardiac output will also stimulate the sympathetic nervous system. Okay. Now, if sympathetic nervous system is stimulated, my dear students, automatically it will stimulate which receptor? Alpha 1 receptor. It will stimulate which receptor? Alpha 1 receptor, which will cause vasoconstriction. Vasoconstriction. Okay. Then, sympathetic activation will also stimulate which receptor? Beta 1 receptor. If beta 1 receptors are stimulated, it will increase the force of contraction of the heart. Okay, and if beta 1 receptors are stimulated, I told you people, what will get released, my dear students? What will get released? Tell me. What will get released? Tell me quickly. If there is a beta 1 activation, very good. That will lead to renin release. That will lead to renin release. Okay. Now, if there is a decreased BP, as I told you people, decrease of cardiac output. If there is a decrease of cardiac output, now what will happen to your kidney? If there is a decrease of cardiac output, it will decrease the blood flow, renal blood flow. If blood flow to the kidney is decreased, again it will cause the renin release. So far what I told you people, understand? If there is a BP decrease, what will happen? Decrease of the BP, decrease of the renal blood flow, sympathetic activation, renin release. So far, whatever I told you people, if you people understood, give me an S. Let's see. Have people understood? Give me an S. Or no, maybe if you didn't understand. Okay. So, if you understood so far, let's go back to our understanding. What exactly I'm trying to teach you people here? Guys, what I'm trying to tell you people is that if there is a vasoconstriction, if there is what? Vasoconstriction, what will happen? Vasoconstriction will lead to, what is that? Vasoconstriction will lead to increase of the BP. Okay. Now, if there is a force of contraction increases, that will also lead to increase of the BP. That will also lead to increase of the BP. Now, renin, whatever is released, what he will do? He will convert angiotensinogen. Angiotensinogen. He will convert angiotensinogen into somebody called as angiotensin 1. Angiotensin 1. Okay. Now this angiotensin 1 will get converted into AT means angiotensin. It will get converted into angiotensin with the help of angiotensin converting enzyme. Angiotensin converting. Now this angiotensin 2 will go and stimulate angiotensin 2 receptor. Angiotensin 2. I'll write it as a normal number so you can remember. Angiotensin 2 receptors. Okay. Once it stimulates the angiotensin 2 receptors, it will also cause increase of the BP. It will also cause increase of the BP because it will cause vasoconstriction. Vasoconstriction. Okay. Now, this angiotensin will not keep quiet. It will also go and stimulate aldosterone. Now, what exactly aldosterone will do? It will retain. What exactly is that? Sodium and water. If sodium and water is retained, more quantity of the blood. If more quantity of the blood, automatically it will lead to what? Elevation of the blood pressure. Elevation of the blood pressure. So far, whatever I told you people, there is a complete story of hypertension. Here only, with this, you can understand the complete drugs here itself. Okay. So alpha 1 stimulation, vasoconstriction. Okay. Then there is what is that? ACE. ACE will convert angiotensin 1 to 2, which will cause angiotensin 2 receptor stimulation, vasoconstriction and elevation of the BP, and there will be sodium and water retention as a result of aldosterone. So what you need to do? Very easy. Target here, target here, target here, target here. So every place in this particular aspect, if you make a target, the story is ending. What is that? Treatment of hypertension. So that's how we need to understand. If you know this particular mechanism, it will be very easy. So decrease of BP. If BP decreases, cardiac output will decrease. Sympathetic activation. Sympathetic activation will lead to alpha 1 activation and beta 1 activation. If cardiac output decreases, renal blood flow decreases. It will lead to renin release. Beta 1 also lead to renin release. Now, because of alpha 1, beta 1 effect, the BP was increased. Because of renin, angiotensinogen got converted into angiotensin 1. Angiotensin 1 will get converted into angiotensin 2 with the help of an enzyme called ACE. Now this ACE will convert it into angiotensin 2. Now this angiotensin 2, whatever is there, my dear students, it will go and stimulate the angiotensin 2 receptor, which will cause vasoconstriction and increase of the BP. At the same time, your aldosterone will cause the retention of the sodium and water, which was stimulated by angiotensin 2. That is the end summary. So what and all you can do? Remove the sodium and water. Sir, treatment of hypertension done. Yes. Inhibit angiotensin converting enzyme, treatment of hypertension done. Sir, for example, block beta 1 receptor, renin not released, treatment is done. Okay, don't allow the blood vessel to contract, keep them dilated, your treatment is done. So this is how we need to understand. Everybody able to follow the follow the logic here, what I'm trying to do? See, this is a very important concept. Okay, now let's start with the first group of drugs, thiazides. Thiazides are drug of choice for hypertension management. Now you people might get confused. It is like asthma only. So what do I mean by this? What is the drug of choice for hypertension? That is the only question. What is the drug of choice for hypertension? Then you are going to mark it as thiazides. So thiazides, my dear students, it is a type of diuretic which will cause the loss of sodium and water, so that will decrease the blood pressure. Drugs such as hydrochlorothiazide. Now, why am I not going into the depth? Because there is a reason. We will teach the diuretics with you, the diuretics in upcoming CVS only. Okay, hydrochlorothiazide. Apart from hydrochlorothiazide, my dear students, these drugs such as chlorothiazide. Okay, chlorothiazide. So there is one more drug chemically related to this called as chlorthalidone. All these drugs are thiazide diuretics. Okay, so I'll teach you people about thiazide diuretics. Just wait. Now, so far, understand this. Let's go to the next important aspect. What exactly is that? Remember your angiotensin 1. Angiotensin 1 used to get converted into angiotensin 2. Angiotensin 2. Now, this angiotensin 2 used to stimulate angiotensin 2 receptor, AT2 receptors. Now here we used to have an enzyme called as angiotensin converting enzyme. Why am I putting this every time again? Now listen to me very carefully. This ACE is located in your lungs, my dear students. Where it is located? Lungs. Now what am I trying to teach you people here? Look here, in the lungs we have an inflammatory mediator called as bradykinin. Now, bradykinin will undergo degradation also with the help of same enzyme ACE. So, ACE is required for conversion of angiotensin 2 and also for the breakdown of the bradykinin. This is a summary you need to understand here. Okay, now let's understand ACE inhibitor. ACE inhibitor, what is the mechanism of action? They will inhibit an enzyme called as angiotensin converting enzyme. If they inhibit the angiotensin converting enzyme, now what will happen, my dear students? Increase of angiotensin 1. But that is not our problem, angiotensin 1, because it is not a potent. No, nothing to worry about angiotensin 1. But there is also, if you inhibit, there is an increase of bradykinin. Now if there is an increase of bradykinin, it will cause one side effect. It will cause a side effect, that is your dry cough. It will cause a side effect called as dry cough. Why dry cough? The dry cough is caused as a result of your, what is that? That is your bradykinin. Okay, since we are talking about the side effect, let me write down here only. In patient, now listen to me very carefully. In patient with C1 esterase deficiency, there is an enzyme C1 esterase. Where it is located? In which pathway it will come? C1 esterase. Let's see. Yeah. So in which pathway C1 esterase will come? C1 esterase, my dear students, C1 esterase will come in one pathway, that is only your complement pathway. Okay, see, in patient with C1 esterase deficiency, very good, it comes in a complement pathway. Complement pathway is a part of plasma protein. Okay, now in that patient, they can lead to a side effect called as angioedema. What do I mean by lead to angioedema? Now, angioedema is nothing but swollen lips, very evident, very severe swelling of the lips will be called as angioedema. That is a side effect. Okay. Now, AC inhibitors, my dear students, let's understand the next important aspect. Now, this most important thing is that drugs. We have drugs such as captopril. We have enalapril. We have lisinopril. All the prils, agreed. All the prils are your ACE inhibitors. Prils are ACE inhibitor. Okay. Now, my dear students, what are the uses of this drug? All of you know, one use is hypertension. Along with that hypertension, they are also used in congestive heart failure. Along with the congestive heart failure, these drugs are used in patients with diabetic nephropathy. Why nephropathy? Why do we use it? Why do you think, okay, diabetic nephropathy came, okay, I felt like ACE inhibitor, do I give? No, not like that. Because we use them in diabetic nephropathy, because they decrease proteinuria. Since they are decreasing the proteinuria, we are using them in a diabetic nephropathy, but not in a CKD. CKD is a different spectrum of disease, but CKD is a different spectrum of disease, and diabetic nephropathy is a different spectrum of disease. Remember, a patient with diabetic nephropathy, then you are preferring your, what is that drug? That is your ACE inhibitor. Okay. Now, what is the important take-home message here? The take-home message here, patient with diabetes mellitus and hypertension. Best antihypertensive. Best is ACE inhibitor. ACE inhibitor. Okay, so remember there, see, that is what I'm telling us. See, in CKD patient directly you are not using, you're using them in a diabetic nephropathy patient so that kidneys will not get into CKD. Okay, so for CKD don't answer directly as a AC inhibitor. That's what I'm trying to tell you. Okay, understood about AC inhibitor? Then next important, they're called as ARBs. What is that? ARBs. The ARBs are what? Angiotensin receptor blockers. Angiotensin receptor blockers. Now angiotensin receptor blockers, already I taught you people here, angiotensin receptor, it will go stimulate, it will cause vasoconstriction. If I block this angiotensin receptor, no vasoconstriction, automatically BP will decrease. Drugs such as losartan, drugs such as telmisartan. So all the sartans are your ARBs. Okay. Now, for example, patient with gout and hypertension. So question number 1. Which drug to avoid? That is question number 1. Which is to be given for hypertension? Which drug? That is which, write it as antihypertensive drug. Which antihypertensive drug? Okay. Now tell me answer. Let's see. So patient comes to you. All these are direct MCQs. Okay. Beat any exam. Every place these are asked. Okay. Now tell me, patient with diabetes mellitus and gout is, hypertension and gout is there. Which antihypertensive drug to be avoided? Which antihypertensive drug to be given? I'll give something, sir. Already it is too late, we are sleepy. No, not like that. So remember which drug to avoid. So remember the drug to avoid are thiazides. Don't get confused. Drug to avoid is thiazides. Okay. Why to avoid? Because thiazides will increase the urea reabsorption leading to gout. So if a patient who is having gout, if you give thiazide diuretic, gout will become worse. So don't give thiazides in a patient with gout. But where you have to give? You have to give which drug to give in this case? You have to give losartan. This is having a slight uricosuric property, means it will excrete the urea a little better. That is why. Very good, very good. Okay, you are correct. Losartan to be given, thiazide to be avoided. Very important MCQ. Got it? Okay. Then, once you have understood about ARBs, let's go to the next group of drugs. What is that? Calcium channel blockers. Now, calcium channel blockers, my dear students, understand in smooth muscle. Which calcium channels are there? In the smooth muscles. So in the smooth muscles, we have somebody called as L-type calcium channel blockers. We have something called as L-type calcium channel blockers. Okay. Now, please understand, consider this is one smooth muscle. Now, what I have here, I told you people, what is that? There is a smooth muscle. To this smooth muscle, I have calcium channels, right? So, what will happen is that calcium will come inside. Now this calcium, whatever comes inside, this will go and stimulate which one? Sarcoplasmic reticulum. What is that? Sarcoplasmic reticulum. What is this sarcoplasmic reticulum? My dear students, sarcoplasmic reticulum is a intracellular calcium storage. Once calcium act here, it will release more of calcium. Now this calcium will cause contraction. Now issue is that in the smooth muscle, which calcium channels are there? L-type. Which calcium channels are there? L-type. Now listen to me very carefully. If you at all you block this L-type, what will happen? If you block the L-type, automatically L-type calcium channel, if they are blocked, it will cause vasodilation. Now listen to me very carefully. Vasodilation is there, caused by what? Smooth muscles. Okay. Now guys, please understand vasodilation. Okay. Now what are the drugs we have? So drugs acting on calcium channels of smooth muscle, calcium channels of smooth muscle. So this is a very important aspect. Which calcium channels are present in the smooth muscle? This is also MCQ which was asked earlier, that is L type. So calcium drugs acting on the calcium channels of the smooth muscle, calcium channels of the smooth muscle, they are called as your dihydropyridines. Dihydropyridines. Okay, now among these dihydropyridines, so if you look at dihydropyridine, if I want to simplify it and pronounce, I can pronounce it as dipine. Dihydropyridine simplified into a dipine. So dihydropyridines are amlodipine, okay. Apart from amlodipine, we have one more drug, that is your nifedipine. Okay. Apart from nifedipine, there is one more drug called as nicardipine. Okay. So all these drugs are your calcium channel blockers. Now, you understood about calcium channel blockers. We understood about the smooth muscle relaxation. They're causing the smooth muscle relaxation. I'm sorry. Now, amlodipine, nifedipine, nicardipine are there. Okay. Now, guys, let's go to the next aspect. Now, what are the uses of the calcium channel blocker? Now, wherever you use calcium channel blockers, my dear students, they're going to cause smooth muscle relaxation. So, all of you know one of them, hypertension. Okay. Hypertension urgency we can use. Hypertension urgency also we can use. Okay, apart from that, next aspect, guys, please understand what exactly is that. So hypertension, apart from that, diseases such as achalasia cardia in a patients with fistula in a node, in there what you are going to is that fistula in a node, there in those patients what you are going to do is that you are going to give it in the form of a cream so that the anal sphincter will relax. In all these places we can use them. Okay, now guys, so if they're causing the smooth muscle relaxation, they will cause some side effect also. Why? Because smooth muscles are present in many places of the body. So if it causes smooth muscle relaxation, what will happen to venous return? Decreases. Whatever blood which is to come from the veins will be decreased. If venous return decreases, they can lead to reflex tachycardia. Reflex tachycardia. Now, apart from reflex tachycardia, my dear students, they will also cause one more side effect. What is that one more side effect? So, in the body, we have GIT, right? GIT is made out of lots and lots of smooth muscle. If there is a lots and lots of smooth muscle, there what can happen is that your smooth muscle can get extremely relaxed and they can lead to constipation. Okay, apart from constipation, motility will decrease now, my dear, because smooth muscles are relaxed. If smooth muscles are relaxed, what is there to motility? Because if smooth muscle contract only, motility is more. Okay, don't confuse. Okay, now don't confuse yourself. Okay, now constipation. Apart from that, there is one more side effect which can be direct question: ankle edema. And one more side effect. What is that? That is your gum hyperplasia. Now, gum hyperplasia can also be caused by ankle edema and gum hyperplasia, specifically caused by amlodipine. Clear, everybody? Clear? Okay. Now, we have one more drug here, nicardipine, is used for intracranial hypertension. Intracranial hypertension means there is an elevated blood pressure in the cranium. In that condition, we are going to use this drug, that is nicardipine. Okay, so we are done with the calcium channel blockers. Once we are done with the calcium channel blockers, ARBs, thiazides, all these drugs are done, then we are going to next group of drugs. What are those? They are your beta blockers. Now, beta blockers will not take much time of yours. Why beta blockers will not take much time of yours? So they're used for both fistula in ano and fissure in ano, no problem. Anyways, excessive contraction of the smooth muscle, you can use it. Okay. Now beta blockers, my dear students, what you are trying to understand. Fissure in ano also we use. Okay. Now, beta blockers, they inhibit the renin release. They inhibit the renin release. Already know. They inhibit the renin release. If they are inhibiting the renin release, automatically they will decrease the blood pressure. They will decrease the blood pressure. So that is a simple aspect. What is that? Beta blockers will decrease the blood pressure. So this is the story of your first line antihypertensive drugs. What are the first line antihypertensive drugs? Thiazides, okay. Then ACE inhibitors. Then you have angiotensin receptor blockers. Then you have calcium channel blockers, and you have your beta blockers. Clear, everybody? It's used for both. It's used for both. Don't worry. Now, once you understood about this, now let's go to the next aspect. What is that next aspect? My dear students, the next important aspect is that is other antihypertensive drugs. Other antihypertensive drugs. So in the other antihypertensive drugs, I'm not going to waste much time discussing every drug, but let's focus on the drugs which are very much important for the exam. Everybody with me? Everybody with me? Able to understand and focus? Yeah, tell me. Okay. So listen to me. Other antihypertensive drugs. The other antihypertensive drugs, such as first and most important drugs, potassium channel openers. What is it? Potassium channel openers. Now, potassium channel openers are very important drugs. Why very important drugs? Potassium channel openers, how do they work? Working is very simple. So, this is a cell. Inside the cell, intracellular fluid rich with potassium ion. If I open the potassium channel, all the potassium will come out. If potassium comes out, cell will become more and more negative. If cell becomes more and more negative, it undergoes hyperpolarization. So, can it contract? If it happens in the smooth muscle, can it contract easily? No, it cannot contract easily. Okay. So, that is the story. So, potassium channel opener mechanism is not important, but the drugs and their uses are very important. We have a drug called as minoxidil. Guys, tell me minoxidil, your favorite beard oil. All of you used to buy beard oil, na? That contains of minoxidil only. That consists of minoxidil only. We have one more drug. What is that one more drug? That is your hydralazine. Hydralazine. Again, very important MCQ. Okay. Now, apart from hydralazine, there is one more drug called as diazoxide. Diazoxide. So, three drugs, three important MCQs. Okay. Now, what are those MCQs? Let's see. And what are the uses? Let's see. Okay. Now, tell me minoxidil. Minoxidil is used. Minoxidil will cause one side effect, that is your hypertrichosis, excessive hair growth. Hypertrichosis. If there is a excessive hair growth, we use it in alopecia. What is that? Alopecia. Which type of alopecia? Usually we use it for androgenic alopecia. Which is that alopecia? We are going to use it for androgenic alopecia. Which is that alopecia? We are going to use it usually? Androgenic alopecia. Androgenic alopecia. So, where we are going to use it? We are going to use it in a androgenic alopecia. Androgenic alopecia. Apart from androgenic alopecia, it is applied how? Topically. My dear students, remember that is not systemically. Topical application only. Systemically for androgenic alopecia, which drug you are going to use? Systemically. Systemically, you are going to use which drug? Finasteride. Which is that drug? Finasteride. Finasteride. Okay, for systemic usage, finasteride. For topical usage is your, what is that? That is your minoxidil. Then hydralazine. Hydralazine used in pregnancy hypertension. So pregnancy female with hypertension, three drugs we have discussed so far: hydralazine, alpha methyl dopa, and labetalol. These three are used for the pregnancy hypertension. Then diazoxide. Diazoxide is used in one condition called as insulinoma. Insulinoma. It is a tumor which will produce excessive level of insulin. So how exactly the rationale behind its usage we will understand during the endocrine discussion. Agreed? Okay. Now, Now, once you understood about diazoxide potassium channel openers, let's get to the next important, such as alpha blockers. Alpha blockers. Alpha blockers we already discussed. A with hypertension, patient with hypertension and BPH, then to decrease the drug's load, we can use just single drug, that is your alpha 1 antagonist. Alpha 1 antagonist. Okay. Then there is one more drug, that is your dopamine agonist, specifically speaking D1 dopamine agonist. My dear students, D1 dopamine agonist, how do you understand this? Please understand, D1 receptor is there, D2 receptor is there, two receptors are there. D1 receptors are located in the periphery, so in the periphery, if D1, if they are stimulated, it will cause vasodilation, leading to decrease of the blood pressure. Okay. D2 is located where? In the central nervous system. Okay. In the periphery, where exactly, my dear students? Exactly speaking, few of the most important location. One of them is renal vasculature. Okay, and mesenteric vessels. These are the two places, most important places, mesenteric vessels. Okay, now listen to me very carefully. D1 dopamine agonist, we have a drug called as, what is the name of the drug? The name of the drug is called as phenoldopam. What is this phenoldopam? Phenoldopam is a drug. What exactly is this phenoldopam? Phenoldopam is a drug which is responsible for D1 agonist. Okay. Now listen to me very carefully. Now what exactly happens here is that D1 agonist is a phenoldopam. So this is one of the drugs which can be used in hypertensive emergency. One of the drugs. Okay. Now, apart from that, guys, you need to remember one of the most important, MgSO4. MgSO4, where do we use it? Used in the eclampsia cases. But most importantly, eclampsia we use them. But when you give a magnesium sulfate, magnesium will antagonize who? Antagonize one of the most important substance, that is your calcium. Basically, magnesium will break the activity of calcium. If it break the activity of calcium, so what will happen? Calcium was responsible for vasoconstriction. Now, what exactly will happen? Vasodilation will occur. Agreed? Understood? Now, MgSO4, that will lead to eclampsia. Now, when we need to understand the next important aspect, when you use a MgSO4, you need to do some monitoring. What is that monitoring you are going to do? What is this monitoring you are going to do? What exactly you are going to monitor? Okay, tell me, what exactly you are going to monitor when you give a magnesium salts? Toxicity. Now, listen to me. If toxicity is happening or not, how will you know? I'm giving continuously magnesium IV, magnesium IV. Okay. But if it is leading to toxicity or not, how will you know? So for that, you need to monitor. Something called as knee-jerk reflex. Knee-jerk reflex. You are going to monitor knee-jerk reflex, my dear students. Please understand. BPH, that is alpha blockers such as prazosin, doxazocin, alfuzosin, terazosin. Okay. Now, not TDM, just you are going to do this particular aspect. Knee-jerk reflexes. You are going to monitor the knee-jerk reflexes. So what you'll get out of knee-jerk reflexes, guys? If at all, see, if knee-jerk reflex is absent, what is that? If knee-jerk reflex is absent, that means magnesium overdose has been occurred. Magnesium has reached a maximum toxicity because calcium activity is not there only. If calcium activity is not there, smooth skeletal muscles will not contract. If no contraction, no knee-jerk reflex. More magnesium, less activity of calcium. Less activity of calcium means less of knee-jerk. If less of knee-jerk means skeletal muscles are not contracting, that indicates magnesium toxicity. So how do you treat a magnesium toxicity? Tell me. Actually, if you use If you use the information which I taught you people only, you can answer. I have a patient with magnesium toxicity. What is the treatment I'm going to do? Very good. The antidote is what is that antidote? Calcium gluconate. Calcium gluconate. So this is the story of your anti-hypertensive drugs. Clear, everybody? Okay. Now, here you write down the drugs related to heart failure. In the patient with a heart failure, what are the drugs you are going to use? Okay, so you need to understand about a heart failure. I'll give you a quick review of the heart failure. What exactly is the quick review of the heart failure? You'll see now. Okay, now patient is having a chronic heart failure. If patient is having a chronic heart failure, there is a decreased pumping of the heart. Simple as that. Decreased pumping of the heart. If heart is pumping less, what will happen? Let's see. If there is a decreased pumping of the heart, that will lead to decrease of cardiac output, which will activate sympathetic nervous system. Sympathetic in turn will activate RAS system. Now RAS system will stimulate aldosterone production. Aldosterone will cause sodium and water retention. But the problem here is that, my dear student, the problem here is that heart is not pumping only. If heart is not pumping, that will lead to more of sodium and water retention. Then what will happen? Now what will happen is that more of sodium and water means more fluid in the body, but heart is not able to pump it. Now that will lead to edema. So this is the cause of edema in your which condition? That is your heart failure patient. Okay. Now, if your heart is not pumping, automatically what will happen? Now, listen to me very carefully. If pumping capability is decreased, that will also lead to decrease of venous return. If there is a decrease of venous return, that will also cause edema. This you can just directly remember. Decreased venous return can also lead to edema. So, a patient with heart failure, one of the complaints is edema. Okay. Now, so whenever patient is having heart failure, heart is not pumping. So what exactly we are going to do? We are going to do first important aspect, the treatment of the heart failure. The treatment of the heart failure, my dear students, we can use beta blockers. Beta blockers will do what? Better filling. Okay, beta blockers will do better filling. That is why we can use these drugs. Apart from that, what else we can use, my dears? The next important drugs we can use is ACE inhibitors. Why we can use ACE inhibitor? ACE inhibitors and ARBs. Okay, now AC inhibitor and ARBs, both of them cause vasodilation. If vasodilation is there, now listen to me very carefully. Your heart is pumping. So if heart is pumping, let's draw and understand. Okay, this is your left atria, left ventricle. Okay, now if you cause a vasodilation, vessels are dilated. Now your heart will pump, but will it have more resistance? See, vessels are dilated, resistance is less, pumping can occur very easily. So that will decrease the load on the heart. That is one reason. And second reason is that if you use this drug, no angiotensin 2, and they will decrease the edema also. So these are the reasons. So ARBs. Apart from that, we can also use, my dear students, diuretics. So all these four group of drugs prevent cardiac remodeling. What do I mean by cardiac remodeling? If your heart is working more, heart can undergo what? Hypertrophy. But if your heart is working less, heart will not have these hypertrophic changes. So if no hypertrophic changes, that will prevent the mortality. So these are the drugs which prevent the mortality also, we can call them. Got the logic? So any drug which decreases the load, which will prevent the mortality. Got it? Now, next important aspect, apart from this, my dear students, we are going to use, what is that? That is your digoxin. What is that? Digoxin. What exactly this digoxin does? Listen to me very carefully. The digoxin is derived from a digitalis plant. Which plant? Digitalis plant, which can also be called as foxglove plant. Now, from this foxglove plant, we get a digitalis. Now, my dear students, digitalis, the mechanism of action is very interesting. So, the first mechanism of action, let's understand, it will inhibit sodium, potassium, ATPase. It will inhibit sodium, potassium, ATPase. Now, if you consider this is one cardiac myocyte, here I have a sodium, potassium, ATPase. Sodium was coming out, potassium was going in. It is present in all the cells of the human body with the help of a ATP. Okay. Now what I will do is that I will block this sodium potassium ATPase. If I block the sodium potassium ATPase, automatically sodium will not come out, so that will lead to increase of sodium in the cell, increase of the sodium in the cell. So increase of the sodium in the cell. Now in the heart there are special pumps. There are special pumps. So that special pump, what it will do, that is your sodium and calcium exchanger. Sodium and calcium exchanger. So what exactly? The sodium will go out, calcium will come in. Means it is a bidirectional. It is a bidirectional. If sodium is going out, calcium will come in. If calcium is going out, sodium will come in. So bidirectional. Okay. Now what exactly is that? Now what exactly happens is that more sodium. Now sodium will go out and you have calcium. So increase sodium in the cell. Now that will lead to increase of the calcium. If calcium is increased, better contractility. Better contractility of the heart. So this is how you are going to cause the increased contractility of the heart. But most important aspect, digitalis or digoxin is there. Now digoxin will compete for one location, compete for sodium or potassium, for the potassium site, of sodium potassium ATPase. Okay, so this is a point to be remembered. So for which side they are binding? Very good, they are fighting for same site. Which site? Potassium binding site, my dear. Which site? Potassium binding site. So understand, if both are, potassium also going there only. See, there is one girl going, two people are interested. Okay, now these two people are competing for the same person. Like that only, there is a potassium site. For that potassium site, digoxin also want to bind, potassium also want to bind. Okay, now what will happen if there is decrease of the potassium? If there is decrease of the potassium caused by hypokalemia, which condition? Hypokalemia. Now if there is a hypokalemia, competition for digoxin will be reduced. Competition for digoxin will be reduced. If competition for digoxin is reduced, now what will happen? So if there is a hypokalemia, that can lead to digoxin toxicity very easily. Digoxin toxicity very easily. So digoxin toxicity can be caused by hypokalemia. Hypokalemia is caused by many drugs. We will understand in the diuretics. So diuretics will lead to hypokalemia. Now hypokalemia can easily lead to what is that? Digoxin toxicity. Digoxin toxicity. So this is the story of your digoxin toxicity caused. Then one next important, now not complete toxicity. The second mechanism of action is that it is a type of vagomimetic in action. If it is a vagomimetic, means heart rate will be increased or decreased, my dear students? Of course, vagus nerve is a parasympathetic nerve. If it is a parasympathetic nerve, automatically it will lead to what is that? Decrease of the heart rate. So it will lead to decrease of the heart rate. If there is a decrease of the heart rate, now what will happen? Bradycardia. Very good, very good. If there is a bradycardia, now what will happen? The duration of diastole is increased. Increase the duration of diastole. Increase the duration of diastole. Something like beta blockers. If there is an increased duration of diastole, now what happens, my dear students? Now the thing is that if there is an increased duration of diastole, that will lead to better filling. Better filling. So these are the two mechanisms. These are the two mechanisms of digoxin. So digoxin is used for very good, very good. Okay. Now the next important aspect is that digoxin related questions. There are some important digoxin related questions. We will understand them now. So let's understand about digoxin toxicity. So the digoxin toxicity clinical features. Okay. Now, what are the clinical features of digoxin toxicity? Let's see. If more digoxin is there in the body, the patient will develop bradycardia. Agree with me? Bradycardia. Why? Because excessive vagomimetic action. Then patient will develop, my dear students, muscle weakness. Which is that condition? Muscle weakness. Okay. Then patient will also develop a condition, that is your vomiting and diarrhea. Vomiting and diarrhea. Diarrhea. Apart from vomiting and diarrhea, patient will also develop one more thing, that is only your yellow halos. Now, what do I mean by yellow halos? So, yellow halos is nothing but the patient will tell, sir, I feel like there is some yellow color light around my head. So, he'll feel that there is a yellow color shade of light which is present around the head. That type of explanation will be given. That is only called as yellow halos. Now, if I have a patient with a digoxin toxicity, okay, tell me the treatment. Let's see. I'm not going to rush here. I want you people to answer the treatment. Okay. So, let's see. So around 38 are watching. I want all 38 of you to give an answer. At least 10 answer I need to get. What is the treatment of digoxin toxicity? Tell me, what is the treatment for digoxin toxicity? I'm looking for your comments. NaHCO3, DS Fab, okay. NaHCO3, okay. Arrhythmic drug, okay. Then any other thing? Digoxin, immune F or digibind, okay. So understand guys, please don't answer. I request you people, don't by-heart it as a digibind. No, not digibind. It is not called complete. There is a complete name. When they gave a complete name, most of the student marked a wrong answer and came. Because of that, if you fail, just imagine how horrible, painful it is. The digoxin antidote treatment is called as digoxin immune, very good, F antibody, immune F antibodies. This is called as a digoxin immune F antibodies. Very good. Digoxin immune F antibodies are the most important treatment. Remember, antidote of digoxin overdose is digoxin immune F antibodies. This is only usually they will call it as digibind. Okay. Now, if digibind is not mentioned in your exam, no problem. Digibind not there, no problem. That is not our headache. What is the main component I need to remember? Digoxin immune F antibody. You need to know this. This is a very, very important aspect because many people made this mistake. What exactly is that? That is the mistake was made with this one. What is that? If there is a digoxin induced arrhythmia. If there is a digoxin induced arrhythmia, then the drug of choice is lidocaine or lidocaine, okay, or lignocaine. So please remember, if digoxin induced arrhythmia, okay, for that condition you are going to use what is that? That is lignocaine. Not for everything, okay. Remember, digoxin induced arrhythmia is there. The drug of choice is your lidocaine, but don't mark it as a wrong answer by rushing into this thing, okay, because there are many times they gave digoxin immune F antibody full name, and since digibind was not there, many people marked lidocaine and lost the question. This is not some old question. This was even asked in some 1 year back in INICET as well. That much frequent question, okay. So I hope you will not make any mistakes. Okay. Now, once you understood about this, let's go to the next important aspect. What is that? So let's understand anti-arrhythmic drugs. They are your anti-arrhythmic drugs. So, anti-arrhythmic drugs. First, before going into, tell me anti-arrhythmic drugs, what and all you know. Anti-arrhythmic drugs. What are the drugs you know? What and all will happen? Tell me. Amiodarone, very good. Lignocaine, very good. Any other thing? Lignocaine, very good. Amiodarone, very nice. Okay. So let's understand about this, okay? Now, my dear students, anti-arrhythmic drugs are going to be little lengthy. Procanamide, very good. Okay. Now, it's going to be little lengthy. I want you people to bear with me. Can you people do that? Can you people do that? Are you people bored of my teaching? Are you people able to understand everything easily? Tell me honestly. Sir, bored means bored. Sir, able to understand means understand. Class 1 to 5. Okay. You're bored. Okay. Okay. Very nice. Happy to hear that. Okay. Anti-arrhythmic drugs. Now listen to me. We will make them very simple. Okay. Guys, anti-arrhythmic drugs. First, before going to anti-arrhythmic drugs, what you need to know, that is about this particular fellow. Consider this fellow is your cardiomyocyte. Consider this fellow is your cardiomyocyte. At the rest, there is a resting membrane potential minus 90 millivolts. So, in a cardiomyocyte of a ventricle, okay, yes, of course, see, once we are doing a quick review, this is how it works, okay, you need to be strong, you are going to be doctors, okay, doctors should be awake in the mid of the night also, the same attention has to be there, that's what we are being trained for, okay. So if I am sitting and giving you 5 hours of full energy, I want you to try the same thing, all right. You'll do that? Okay, Rahman? Motivated? जोश है? Good. 24/7 अवेक रहना है, ठीक है? 24/7 अवेक नहीं रहना है, अवेयर रहना है, अटेंटिव रहना है, बस जरूरत के हिसाब से, according to the requirement. Okay? Now listen to me very carefully. So anti-arrhythmic drugs. So how is the Josh? Hi, very nice. Now listen to me what I will do. All of you studied one thing now. Depolarization, cardiomyocyte activation, cardiomyocyte signal comes, signal. What is that signal? Cardiomyocyte will get signal from what? So girlfriend will give signal and cardiomyocyte get activated or what? No, right? So cardiomyocyte will get activated with the help of entry of sodium ions, my dear students. What happens? Sodium ion comes inside. Now once sodium ion comes inside, cell will become more positive and more positive. It will reach up to a point called as minus 55 millivolts. It will reach up to a point called as minus 55 millivolts. During this minus 55 millivolts, it will lead to opening of more sodium channel. Opens even more sodium channel. If it opens even more sodium channels, it will allow the entry of more and more sodium. The first thing what happened, signal generation means sodium ion entry. So that led to minus 55. After minus 55, it opened more and more sodium channel. The cell will become more and more positive. Cell will become more and more positive. So let's take one graph here. Okay, the cell was at rest it was minus 90 millivolts. Okay, now at this minus 90 millivolts, I opened the sodium channel. Because of that, sodium entered. Sodium is a positive ion, cell became more positive. It came up to, sir, minus 55. Okay, now after minus 55, even more sodium channel opened. More sodium came in. If more sodium comes in, the depolarization will reach to a peak. So sodium channels will reach to a peak. After they reach to a peak, the sodium channel will close. Once sodium channel will close, cell is more positive. Our body is tend to what? Go back to its original state. So body will try to go back to its rest. So during that effort, what it will do? It will open up potassium channel. Now intracellular fluid consists of more potassium. So potassium will start to go out. As potassium start to go out, what will happen? The cell will become, what is that? Cell will start to become negative. But because of this sodium ion entry, potassium exit, entry, exit, that created somebody here, my dear student, that is called as voltage. Now, what exactly this voltage will do? It will allow the entry of calcium ions. So, calcium is coming in, potassium is going out. I didn't close the potassium yet. Focus here. Calcium coming in, potassium going out. Calcium coming in, potassium going out. So if they are looking at one positive coming in, one positive and going out, the voltage will remain unchanged. Voltage will remain unchanged. But at one point, calcium channel will also close, but potassium channel will remain open. Okay, if potassium channel will remain open, potassium is going out, cell will come back to its original resting state. Cell will come back to its original resting state. Okay, now what exactly I'm trying to tell you people here? See guys, in cardiovascular system, the information which I taught you people is very, very valuable. Don't neglect it. Okay, so why am I teaching you people this much? So I can go just like, I can skip into anything. I can just tell class 1 to 3, then story is over 4, and okay, some 4-5 lines because it is a review, but I don't want to do that. I want to do the justification for your time. Okay, so look here, you need to understand. This phase is called as phase 0 initially. Phase 0. Then next, when it is coming down first time, phase 1. Then we call it as a phase 2. Then we call it as a phase 3. When it come back to rest, phase 4. Okay. So phase 0 is only called as, see, the original polarity was minus 90 millivolts. It went to some different positive voltage. Whatever original polarity was there, that was being lost. We call it as depolarization. Depolarization. Okay, then you had phase 1. Phase 1 is called as early or initial repolarization. You'll understand what is repolarization, just give me a minute. Okay, then phase 2, there is no change. If there is no change, very good, already you people told, what do we call it as? Plateau. What do we call it as? Plateau phase. Okay, then phase 3. Phase 3, what is happening? Notice here, it is coming back to its original state. Means what happens is that it is coming back to its original state, means regaining its own polarity. We call it as repolarization. We call it as what? Repolarization. Repolarization. Now understand the next aspect. What is that? Phase 4. Phase 4 is that resting membrane potential. So totally phase 0, 1, 2, 3, 4. 0 is caused by sodium ion entry. Phase 1 is caused by potassium ion exit. Very good. The next one, very good. The next one is plateau, calcium entry, potassium exit. Third one is potassium exit called as repolarization. The last one is resting membrane potential. Resting membrane potential. Now, why did I teach you this? My dear students, during this period, here, this particular area, this particular timing, we call it as absolute refractory period. What is that? Absolute refractory period. Okay, now during this absolute refractory period, you give any energy, you give any extra voltage, heart will not respond. So if heart is under absolute refractory period, give any extra voltage, it will not respond to that much. If you remember, rest will become easy. Okay, so what we are going to do, when you're talking about arrhythmia, what can cause arrhythmia? Such as ectopic beat generation. Ectopic beat generation. Now, ectopic beat generation means normally signal generates from SA node, everything was in sync. Okay, remember, you are right about refractory period. Remember the absolute refractory period, because there is something called relative refractory period also. In physiology, you will learn. Okay, now if there is a ectopic beat, abnormal beat generation from an abnormal location, now what will happen is that normally SA node was generating the signal. Instead of SA node, some abnormal tissue is generating the heartbeat, because of which the person developed a arrhythmia. Now what you need to do, so to treat arrhythmia, to treat what is that? Arrhythmia, you need to do only one thing. Either increase absolute refractory period, your problem is solved, or you can do one more thing. Decrease the absolute refractory period, your problem is solved. Just remember this much. This is enough for you. Sufficient. Okay, either increase, decrease, your problem is solved. Okay, so let's solve the problem. So when we want to solve the problem, how exactly we are going to understand? So guys, antiarrhythmic drugs are divided into, what is that? They're divided into class 1 antiarrhythmic drugs. Class 1 antiarrhythmic. So when you're learning about class 1 antiarrhythmic drug, all the class 1 antiarrhythmic drugs, they will block sodium channels. They will block sodium channels. They will block the sodium channels. Okay. Now we have class 1A drugs. We have class 1B drugs, class 1C drugs. Okay. Very good. Tell me why we have class 1A, why we have 1B, why we have 1C. Tell me. So all of them are blocking sodium channel. Story is over now. Sodium channel blocking property are called as class 1 drugs. But why we divided them into 1A, 1B, 1C? Tell me. Sodium channel configuration or any other extra reason is there? There is one more important aspect. What is that? The other effects, see, not just sodium channel, there are potassium, there are calcium, there are other channels, right? So along with that sodium channel blocking, they also block some other channels. Very good. So class 1A drugs, they block the sodium channel and also they block the potassium channels. Now class 1B drug, they block the sodium channel and open potassium channels usually. Open potassium. Got the logic? Then class 1C, they block only sodium channels but no effect on the other drug. Very good, very good. Okay, now, so first let me teach you a technique to remember the drugs, then we will go into some graphs. Okay, what exactly is that? The first thing, my dear students, what exactly is that? Listen to me. We have a drug called as disopyramide. Disopyramide. Okay, you have one more drug called as quinidine. We have one more drug called as quinidine. Okay, then we have one more drug called as procainamide. Procainamide. Okay, then very good, very good, very good, very good question. Very good, Rahman. All of you are correct. Okay, now class 1B drugs. Class 1B drugs. So there is one more drug called as lignocaine. Lignocaine. And there is one more drug called as mexiletine. Mexiletine. Okay. Now, the last group of drugs. Last group of groups. There is flecainide. Flecainide. There is one more drug called as propofol. Propofol. Okay, now why am I talking about these drugs only? Guys, there are other drugs also, but if you remember these important drugs, you can survive very easily. And to remember these important drugs, I have a technique to remember. So that technique is, this is a story of a person who went to England. Consider somebody went to England. Okay, now this fellow went to England. When he went to England, what is the currency of England? What is the currency of England? What is the currency of England? Tell me. Guys, come on, it's a general knowledge. GBP, what is you call simple as that? Pounds. Simple as that, pound. So, he went, he gave a pound, he gave 1 pound. He gave 1 pound. Along with that, when he gave 1 pound, he asked for 1 more pound. So, he gave double pound. He gave double pound, 2 pounds he gave, and bought a quarter of whiskey. Bought a quarter whiskey. Quarter alcohol. Bought a quarter alcohol. Okay, so he gave what? Double pound for 1 quarter. He gave double pound for 1 quarter. After that, he drank the alcohol. He drank the alcohol and now he's hungry. Now he's hungry. When he's hungry, he went for what? McDonald's. Okay. When he went to McDonald's, what is the most common thing you are going to buy? Burger. So he asked for a burger. In the burger, he asked for extra. What is that? Lettuce and mayonnaise. He asked for lettuce and mayonnaise. Okay. So now leave about the drinking part. Okay, now leave about the drinking part, leave about McDonald's, but he got hungry, he went to McDonald's, there he went and bought a burger. When he got a burger, what did he ask for? He asked for extra lettuce and mayonnaise. Lettuce and mayonnaise. Okay, now Now, after that, my dear students, what happens? Let's see. So, what happens is that you need to understand some interesting aspect. What exactly is it? Guys, 1 second. I'm having some difficulty here. Yeah, I'm able to see your comments. Okay. So, if you follow so far, now listen to me very carefully. What is that? Lettuce and mayonnaise. He asked for a burger. In that, more of lettuce and mayonnaise. After he ate burger, he wanted more of food, but he was not able to eat one complete burger. He went and asked the server, "Give me fries, please. Give me the French fries. Fries, please." So this is a mnemonic. This is a mnemonic. One person went and got a quarter. He drank that quarter. D for disopyramide. Look here. D for disopyramide. Pound. P for prokenamide. Q for quinidine. First group of drugs done. After he drank the quarter, what he did? Went for a burger. L for, in that he wanted more of lettuce. So L for lettuce, lignocaine. M for mayonnaise, mexilitine. Okay, then he asked for French fries. So flecainide, fries, propofol, please. So how do you remember? Person got a double quarter for a pound. Okay, or double pound for a quarter. You can remember either way. Double quarter for a pound or double pound for a quarter. Okay, he gave double pound for a quarter. He got alcohol, drank, then French fries, before French fries, lettuce, mayonnaise, then fries, please. This is a technique to remember. This is a technique to remember. Will you remember now? Okay. Shall we do this again? Double pound for a quarter. D for disopyramide. P for prokenamide. Okay. Q for quinidine. Done. Then he went to eat the food. That is that burger. In that he wanted more of lettuce, lignocaine. M for mayonnaise. That is your mexilitine. Lettuce and mayonnaise. Then 1C, your what is that? Flecainide and propofol. Will you remember these drugs now? Double quarter for a pound, double pound for a quarter, or then lettuce, mayonnaise, fries, please. Done. Everybody got the logic? This is a technique to remember. Okay. Who will remember all those many drugs? Nah? That is why. Okay. Now, my dear students, let's talk about graphs of each drug. Class 1A drug. Now, class 1A drug, understand this is a normal conduction depolarization in the heart. Okay. Now, what happened? Sodium channels are blocked. Sodium channels are blocked means phase 0 will get, yes sir, delayed, of course. Phase 0 will get delayed. So, phase 0 got delayed. Okay, sir. Then it was going normally. But you are delaying which phase? Phase 3. If you delay the phase 3, so it will become like this. Now, if you notice the new graph which I have drawn with the red color, what happened here? Overall, there is an increase of absolute refractory period or treatment is done. Never ever forget. Very good. Okay. Got it? Then let's go to the next one. What is that next one? Class 1B drug. Same, original depolarization curve was like this. Okay. Now what exactly it does, my dear students? So sodium channels are blocked. Phase 0 is delayed. It was going, rest was going normally. But phase 3, if you open potassium channel, phase 3 will occur earlier. Phase 3 will occur earlier. So it will become like this. It will become like this. The new graph, if you notice here, again there is a decrease of absolutely refractory period. Your treatment is done or not done. That's it. That is why I told you people about sodium potassium channels of the heart in the starting itself. Okay. Now, class 1C, consider this is the original graph. Okay. In this original graph, they are blocking which channels? Sodium channels. They are blocking which channels? Sodium channels. Rest everything is going normally like the old one. If you notice here, there is a decrease of the absolute refractory period. That is why we are treating arrhythmia. 1C. Done? That's it, sir. Antiarrhythmics. So much scary drugs. They're not scary at all. Come on. Very easy. Okay. So once you understood about class 1 drugs, let's go to the next group of drugs. Next group of drugs. The next group of drugs are, let's learn about class 3 antiarrhythmic drugs. Sir, have you gone mad? What about class 2? We'll come to class 2. Just wait and watch. The technique is very important. Okay. Class 3 antiarrhythmic drugs. Class 3 antiarrhythmic drugs, they are the blockers of potassium channel blockers. They block which channels? Potassium channels. They block which channels? Potassium channels blockers. Okay, so what are the drugs? Let's see. Tell me the drugs, guys. Let's see. Okay, tell me the drugs. Let's see. Anybody, if you can remember. Already, people told one drug. What was that drug? What was the drug you told? Amiodarone. Remember? Amiodarone. We have a drug called as amiodarone. Amiodarone. Okay, amiodarone. Apart from amiodarone, there is one more drug, that is your. See, this is the point here. Though it is a beta blocker, though it is what? Beta blocker, it works as a class 3 antiarrhythmic also, called as sotalol. Called as sotalol. Okay. Now, apart from sotalol, there is one more drug called as vernaculant. Okay, so there are many of them. At least remember these three drugs: amiodarone, sotalol, vernaculant. Vernaculant is a antiarrhythmic drugs which is used in trials and etc. recent times. So it is becoming very important drug. Okay, so remember these three drugs. Now what happens, guys? Watch the magic here. The original graph. Okay, to this original graph, what did I do, sir? I blocked the which channels? Everything is going like this only. Normally, I blocked which channel? Potassium channel. So this phase will become prolonged. So if you notice, yes, you treated arrhythmia, increase absolute refractory period. Increase the absolute refractory period. Okay, now remember one more aspect. This amiodarone blocks almost all channels, almost all channels, sodium, potassium, calcium, every channel it can block. Okay, now let's continue the next aspect. What is that, my dear students? This amiodarone is a very important aspect. Why? Because amiodarone can lead to it. This drug contains iodine. The drug itself contains what? Iodine. If it contains iodine, it can lead to side effects. It can lead to side effects such as hyper or hypothyroidism. It can lead to either of them, hyper or hypothyroidism. Hypothyroidism. Apart from hyper or hypothyroidism, there is one more thing. What is that? That is your hyper or hypothyroidism. There can be patient can develop a cataract. Sorry, not cataract, corneal precipitate. What is that? Corneal precipitate. Corneal precipitate. Corneal precipitate leading to blindness. Okay, peripheral, what is that? Peripheral neuropathy, it can lead to neuropathy. Peripheral neuropathy. It can also lead to lung fibrosis. So all these things can occur as a result of using of amiodarone. These are the most important side effect you need to remember. Okay, so this is what is about amiodarone. Once you learned about amiodarone, my dear students, let's go to the next aspect. What is that next aspect? So class 2 antiarrhythmic drugs. Class 2 antiarrhythmic drugs, they are your beta blockers. Basically, they are going to block what is that? That is that is in SA node. They are going to block in the SA node. They're going to block in the SA node, will lead to decrease of the heart rate. Especially what exactly they're blocking. Let's see, my dear students. In the SA node, how depolarization will occur. So consider this is one SA nodal cell. This is one SA nodal cell and we are having a graph here. Okay. Now what happens is that the cell will be at rest. Okay, but there are something called as IF channels. Which will allow the entry of small amounts of sodium without any depolarization, without requiring anything. So from the rest, it will be rising slowly like this because of IF channel. It will reach one point called as threshold potential. As soon as it reaches the threshold potential, my dear students, it will allow the entry of calcium ions. What will happen? Now, as soon as it reaches, it will allow the entry of calcium ions. So it will reach a peak. After that, calcium channels will close. Once calcium channels will close, the cell will come back to its original state. Again, the same story will repeat. Slowly it will rise. Suddenly calcium will come in and the same story will repeat. Each of these particular thing is equal to that of 1 beat. is equal to that of 1 beta, is equal to that of 1 beta. Now, how exactly it is coming back? Of course, repolarization, potassium exit or potassium efflux, exit or potassium efflux. Okay, so this is the story of your SA nodal depolarization. Okay, now, now, where there is a repolarization is occurring, what do we call that state as? Repolarization is occurring, we call it as a phase 3. Okay, now, do we have a phase 0 here, guys? Do we have a phase 0 here? Tell me in SA node, do you have a phase 0? So calcium entry depolarization is occurring. Calcium entry depolarization occurs. That means which stage is that? Depolarization is occurring. Which stage is that? So that is only your phase 0 and phase 4. Okay. Now listen to me very carefully. So please understand these are the phases. Okay. Now please understand, leave about the phases also. It's okay, learn from the physiology. But the thing is that beta blockers prolong this phase. Beta blockers will prolong this phase. Once they prolong this phase, automatically what will happen? Beat generation will be slower. Prolong this initial phase. Okay, yes, of course, phase 1 and 2 absent, phase 1 and 2 are absent. Okay, so this is your phase 4. Beta blockers prolong phase 4. Phase 4. Phase 4. This is only your phase 4. Okay, it will prolong the phase 4. Then the last group of drugs what you have are, that is your class 4 antiarrhythmic drugs. They are your calcium channel blockers. Calcium channel blockers. Now these calcium channel blockers, my dear students, what are the calcium channel blockers we have? The calcium channel blockers are diltiazem and verapamil. Okay, now this diltiazem and verapamil, exactly they are working where? Here I told you people, which is that phase? Phase 0, phase 0. If calcium channels are blocked, automatically see, normally SA nodal depolarization was something like this. If you block the calcium channel, this will be okay. But calcium channel blockage will lead to slow down because it will take more time. If it takes more time, automatically number of heart rates will be decreased. So that is what is done by your calcium channel blocker. So class 2 and 4, they are working where exactly, guys? They are working exactly in the SA node. Okay, now the problem is there. What is that problem? There are MCQs related. Before going to MCQs, you might be asking, sir, other antiarrhythmic drugs. Sir, other antiarrhythmic drugs, I'll put it into the MCQs, all the important aspect. A patient is having atrial fibrillation. What is the best drug? For atrial fibrillation, beta blockers are equally effective to that of calcium channel blockers, my dear. Equal to that of calcium channel blockers. Then, if at all patient is having a ventricular fibrillation or ventricular flutter, which is also called as ventricular tachycardia, that is ventricular flutter. Okay, in that condition, what you are going to do? The first treatment is defibrillation. Okay, then if I ask you people, during defibrillation, we are going to do what is that? That is only advanced cardiac life support. During the advanced cardiac life support, we are going to use amiodarone. During advanced cardiac life support, we are going to use amiodarone. Okay, apart from that, if I ask you what is the single best drug of choice, you can also use lignocaine. Okay, so to prevent this from occurring, see, during resuscitation, during cardioversion and during your cycles of resuscitation, you are going to use, my dear students, amiodarone. Later, to prevent, what you are going to use? Lignocaine. Now, apart from ventricular fibrillation, let's go to the next aspect. If the patient is having a PSVT, For PSVT, we are going to use IV adenosine. But for PSVT, not just IV adenosine, other treatments are also available. What are the other treatments we are going to do? Other treatments which we are going to do for these people are like this, my dear student. The first treatment, what is that? PSVT, IV amiodarone. Apart from that, there are other things, other treatments such as carotid massage. Okay, there is one more thing we can also advise the patient, Valsalva manure. Okay, these things and other drugs we can consider are beta blockers. But the first and the most important best drug of choice, always your answer is adenosine. Other things are here. Your best drug of choice is adenosine. Okay. Now, if I ask you people, the best antiarrhythmic for WPW syndrome, Wolff-Parkinson-White syndrome, we are going to use one drug called as, my dear students, flecainide. For example, if I ask you people, what is the treatment for, that is only your treatment for digoxin-induced arrhythmia. See, digoxin-induced arrhythmia, the treatment is your lignocaine. Very good. All right. So these are some important aspects which you need to remember. Okay. Now, these calcium channel blockers are they derivative of dihydropyridines or non-dihydropyridines? See, in antihypertensive, I told you about dihydropyridines. Remember? So these are only called as non-dihydropyridines. Clear? So this is a story of your antiarrhythmic drugs. So you treated heart failure, you treated angina, you treated what is that? Arrhythmia, you treated all the possible hypertension, etc. So this is a story of your antiarrhythmic drugs. So somebody might be asking me, sir, is it only enough for every exam? Yes, I can say for every UG level survival or UG level exams, for everything, for even MCA, for any other exams, for your PG also, all the basic questions can be covered related to antiarrhythmics from here itself. So this is the information which you should know. Done, my dear students? Understood everybody? Understood? Okay. So, shall we continue? Let's see. Yes, no? Yes, okay. Yes. Wow. What about others? Very good. Peace. Then we are continuing, okay? So we are going to do one small system, very easy system. Okay, I'm not going to torture you people. I know that. After cardiology, anything which comes to brain, don't, reflex, everything, overhead syndrome only. But let's make it simple. Okay, that's natural. Okay. I only told you people 45 minutes is the span and I'm teaching you people. You people might be thinking, see, this is a review, you need to adjust. Okay. And those who are thinking, sir, my girlfriend is waiting for me to text with me. So leave all those for a day and listen to the class. Okay, it's fine. Now, in quick review of pharmacology, nobody is going to teach you in this depth. This is very clearly I'm telling. Okay, so please. All right, chala. Let's start. Understand? Very easy, sir. Very easy system. GAT. What is that? GAT. Okay. Sir, I want to do Babu Shona. You can do all your Babu Shona later. Okay. Right now, GAT. Pet puja karte. Okay. That's true. Okay. Now, guys, in the GIT, that's very easy. The first and most important thing I want you people to understand those drugs which are used for the peptic ulcer disease. Okay, for treating of the peptic ulcer disease. So let's understand drugs for the peptic ulcer disease. So when you want to understand about the drugs for the peptic ulcer, guys, it's very easy for you to understand. So what are the drugs we have for peptic ulcer? Okay. So this is what I wanted to hear. Not just PPIs. Okay. There are other things also. Now listen to me. What exactly happens here? So drugs for peptic ulcer. What are the causes for the peptic ulcer? Causes for the peptic ulcer. Some of the leading ones. H. pylori. H. pylori. Then drugs such as NSAIDs and steroids. Most important ones, okay, I'm talking. Then apart from that, other risk factors such as lifestyle, etc., all of them. Okay. Now, when you need to understand that, my dear students, let's take stomach. Now, inside the stomach, we have hydrochloric acid. Now, hydrochloric acid is not touching the stomach. Hydrochloric acid is not touching the stomach. Rather, there is a mucus barrier. This mucus barrier prevents the hydrochloric acid from damaging the stomach. Okay. Now, listen to me. Let's understand. So, let's learn about acid production. Acid production is done by acid production, how does it occur? Done by your parietal cell. How exactly it happens? Let's see. So, how exactly it happens is that, guys, normally the parietal cell looks like this, something like this, okay? This is the normal shape of a parietal cell approximately, but we are going to make it into simplified fashion. So, let's take a parietal cell. This is a parietal cell. Okay. Now, in the parietal cell, right next to parietal cell, there is some other cells, my dear student. They are only called as ECL cells. ECL cells. Okay. Now, listen to me very carefully. You eat food. Food will stimulate parasympathetic nervous system. Parasympathetic nervous system will release acetylcholine. Now, acetylcholine will act upon the enterochromaffin-like cell and also act upon your parietal cell. In the parietal cell, which receptor is there? M1 receptor is there. Okay. Now, apart from that, food will also lead to the production of gastrin. Now, gastrin will act upon the gastrin receptor. Okay. Now these enterochromaffin cells will produce histamine. Now, histamine will act upon your H2 receptor. Clear, everybody? Enterochromaffin-like cells. Okay. Don't confuse. Now, gastrin receptor will allow the entry of calcium. M1 receptor will allow the entry of calcium, and H2 receptor will convert ATP into CAMP. Now, if you notice here, calcium, CAMP, calcium, all these three things will activate a protein kinase. Now, this protein kinase will trigger the protein synthesis. Now, this protein will come and sit on the cell membrane. So, this protein will pump. What exactly is that? It will pump the hydrogen from inside of the cell to outside of the cell. And it will take which ion? Potassium ion into the cell. Now, this hydrogen ion will combine with the chloride ion, leading to your hydrochloric acid formation. Clear? Okay. Now, what exactly we are going to do? So, we need to decrease the acid secretion. The first drugs are your proton pump inhibitors. Now, what are these proton pump inhibitors? So, proton pump inhibitors are the drugs, your prazole, such as pantoprazole. We have rabeprazole. We have lansoprazole. We have esomeprazole. All the prazoles, which are what exactly they are doing? They are blocking this particular stage, proton pumping. We call this stage as only they are the last stage of acid production blocker. Then we have H2 blocker. H2 blockers such as ranitidine, nizatidine. Then we have one more drug, that is your cimetidine. Cimetidine. Okay, now cimetidine, there is one important MCQ you need to remember. It will cause a side effect, that is your gynecomastia. I told you people yesterday. Okay, this is a very important MCQ, gynecomastia causing drug. Then digoxin will also cause, gynecomastia also caused by digoxin addict. Also caused by your digoxin. Okay, now apart from this, there are some M1 blockers which I taught you people already. M1 blockers such as your pirenzapine and tilenzapine, they are also decreasing the acid production. Okay, now what exactly you need to focus here, my dear students? We need to focus treatment of H. pylori. Treatment of H. pylori. So this is a very important MCQ. Okay, usually we are going to use something called as triple therapy, and there is one more thing called as quadruple therapy. Now, what is the difference between these two? Triple therapy will consist of two antibiotics and one proton pump inhibitors. Quadruple therapy is what? Two antibiotics and one PPI, along with that one covering agent. What is that? Covering agent. Now covering agent, the classic covering agent, you need to remember. What is that classic covering agent? That is your bismuth subcitrate. Okay, this is the aspect. Now, if I'm telling antibiotics, so two antibiotics, what are the antibiotics we can use? So I'm going to give you a list of 4 antibiotics. So what are those antibiotics? Write down, that is only your amoxicillin. Okay, then there is a clarithromycin. Then we can also use tetracycline. Okay, anybody can tell me any other drug? That is metronidazole. Very good. That is your metronidazole. So among these 4 antibiotics, any two. Among the 4, what is that? Any 2 antibiotics along with that one PPI, then it is a triple therapy. To triple therapy, if you combine, what is that? That is your covering agent, bismuth subcitrate, then we are going to call it as a covering agent. That is only covering agent called as quadruple therapy. Okay, so this is the story of your H. pylori treatment. All right. Okay, so if you know this much, there are some small things about treatment. See, I need to quickly review about treatment of vomiting. Along with treatment of vomiting, diuretics and the rest of the topics we will have to discuss, that we will discuss tomorrow. Is that okay for everybody? I know that. So these drugs has to be completed. That is the purpose of doing it very quickly. But the thing is that I want you people to understand these are the most important things to be remembered. So with this much being said, we will conclude here for today. So please tell me, have you people able to get all the information properly, assimilate all the information? Are you people able to assimilate all the information? Feel it useful or not? Okay, so what you need to do is that, so if you are using these sessions and if you are getting advantage, not just you, share it to all your friends, let them also learn from this. Okay, see you people tomorrow. We will announce the schedule. Everything will be announced, posted in the group. All right, thank you so much. Good night.